Yo, what's up? I'm QR Terry, and you are now watching Vertigo. Thank you for joining us. The people who are just joining, please let us know in the chat where you're coming in from. We're glad to see that this is a worldwide event. I've been seeing some of the registrations come through. We have live on screen Brooke Pierce, or Dr. Brooke Pierce, and Amy Lennox Bowley. I'm messing up. Sorry. Bowley. I will not do that again. I really apologize. I'm sorry about that. Lots good. We're at Vertigo Day. Tell me how it all kind of came together. I know Dr. Pierce reached out to me a few days ago, or it feels like a few days ago, and we were just like, hey, we're going to do this Vertigo Day thing. But Amy, I know, got involved. And for the people that are just now watching and tuning in, how did this come together?
Well, I think the excitement really is pulling kind of this worldwide group of resources together. And Amy and I, for a long time, along with Chelsea, have known, what happens in our clinic, happens all over the world with regard to lack of resources. So by the time we're seeing patients, the frustration level of the lack of what's in their immediate area or what they need, it's frustrating. And so we just really thought, we'll throw something together for patients, that we know need the resources, but at the same time have a very candid, very honest conversation about what's currently out there.
Yeah, and I'm very much the same. So, I always quote the stats, which are, it takes usually 4 specialists and between 4 and 5 years before a patient gets a clear diagnosis with what's going on with their dizziness. And, me and Brooke have been working together a lot, trying to disseminate information, getting information out there. And this just seemed like a perfect opportunity, especially with lockdown, to pull all our resources together and see if we could put something really strong together for our patients.
Wonderful. We're getting a little bit of feedback from, I think, your end, Amy. Just check your internet connection. It's a little, or if you have headphones, please put headphones on. I think that might fix that issue.
I'll grab some headphones.
We're almost 100 people watching us live. Dr. Pierce, you have a presentation that is about to start here momentarily. Could you give a little bit of background into yourself, what brought you into starting the Dizziness and Vertigo Institute of Los Angeles, and what you're excited to talk about today at the at Vertigo Day?
Yeah, so I think one of the biggest things is I truly believe that knowledge is power. And so as a patient, whether you are experiencing vertigo yourself or you actually have a family member or a loved one, understanding what's happening in the system is really important. And so putting together just a little presentation, not only visually, but with some information that has a little bit of substance from a medical standpoint, but a lot more kind of functional application was our goal. So that's kind of where we wanted to kick things off with regard to the Dizzy 101 discussion. And then, as far as myself, again, kind of echoing, the lack of resources and knowing that I have such a passion for helping people return to their normal state. Chelsea and I just knew that opening a practice that had emphasis on the dizzy patient, not only diagnostically, but the solutions. And so that's why we opened the Dizzy and Vertigo Institute here in LA, is because, from beginning to end, we're able to hear the story, plug in the science, and then get the actual resources together for the patient. It's a very exciting and very gratifying process for everybody involved.
Wonderful. Now, Brooke, before we get started, I know Amy is back. Amy, are you back?
Yes. Can you hear me?
Yes. What are you most excited to learn from Dr. Pierce's presentation today, Amy?
Well, I know that Dr. Pierce has been using very kind of new techniques, very forward thinking, not scared of kind of challenging that paradigm that maybe some of us dizziness specialists have been stuck in for the last 20, 30 years. And I know that what Dr. Brooke is presenting and gives to her patients is very innovative, very pioneering, and kudos to you for pushing forward and delivering that for your patients.
Wonderful. Oh, what we're about to do is we're going to go ahead and get started. We have about 130 people watching us live. Hello, everyone. Please let us know where you're coming from. We're excited to see all the locations. We're throwing that stuff up on screen as you come in. And we will be in the comments. So if you have any comments or questions, feel free to drop us an email. I'll put that email on screen momentarily, or you can just leave it in the actual chat and we'll get to it as well. So with that being said, I'm going to kick over to Dr. Pierce, and we're going to start up your presentation. How do you feel about that, Dr. Pierce?
I'm excited. Let's see. Here we go, guys.
All righty, here we go.
All right. Well, thank you guys so much for joining. This is actually really exciting. We're going to go ahead and kick things off. My name is Dr. Brooke Pierce. I am one of the co-founders of Dizzy and Vertigo Institute in Los Angeles. We are Audiology Corporation, and all up to you in just a moment. So the reason you all are here is because either you or someone you love is actually affected by dizziness. And so dizziness is pretty complicated. So I'm going to start breaking things down. But our mission as specialists or specialists that work with dizzy patients should be clear. So our job is to help dizzy patients translate the complexity of these symptoms into real solutions. And, you know, it's really important to work in a collaborative environment with a collaborative approach, working with patients' physicians, working with occupational therapists, physical therapists, audiologists, chiropractors, dietitians, the list goes on and on and on, to really manage and treat vestibular disorders. So I'm going to break down what an audiologist is because it means different things in different parts of the world. In the United States, I'm going to read straight from the slide because it's a little bit of a long slide, but it's a clinical specialist that's uniquely qualified in a comprehensive way to identify, evaluate, habituate, and rehabilitate those of impairments of the auditory and then the vestibular system. Audiologists are professionals who identify, assess, and manage these disorders of the auditory, balance, or other neural systems. So one of the biggest pieces of the puzzle when we get into dizziness is, what does it mean? Because dizziness really is an umbrella term. When we sit down with patients, we ask them to just go ahead and tell us how they're feeling, explain their symptoms of dizziness to us. And we get a whole slew of descriptions. Dizziness is the umbrella term, and underneath it is going to fall the actual description. So vertigo would be a spinning sensation, imbalance, disequilibrium, rocking, swaying, lightheadedness. We even hear walking on clouds, or that they feel very visually disturbed. So whether they're seated or you know, kind of watching things from side to side, it just feels like a big disconnect. Fuzzy vision, fatigued eyes, also a woozy sensation, even a floating sensation. Sometimes we hear it's sort of like an out-of-body experience, tendency to fall, unsteadiness, even a swimming sensation, hypersensitivity to really crowded or busy environments. So that could even be like at a basketball game or walking around the street, you know, on a busy sidewalk. And then also spatial disorientation. So really feeling that there's a big disconnect between where your body is in space and where you physically are supposed to be in space. So here's what gets extremely complicated. So dizziness is a symptom of everything. And so you're going to hear that throughout the day, that it's very complicated because it kind of sprinkles throughout specialties. So dizziness can exist from a cardiovascular component, from a neurological component, metabolic, vestibular, which we're going to get into a lot today, a visual impairment, psychological, diet and nutrition, medications or changes in medications, head injuries, drugs, alcohol, the list goes on and on and on. So I think these statistics are pretty fascinating, and the more education we get out there and the more that these stats become common knowledge, the more resources that we can all tap into. So a third of all dizzy patients are actually, when they're reporting to healthcare professionals, can be broken up to vestibular patients, or the inner ear is actually involved. So before I get too deep into it, I'm going to kind of high level the 101 discussion today, and then each clinician and physician that's going to be presenting today will take a deeper dive. But to think about all of those descriptions that I just went through, from cardiovascular to neurology, and again, the list goes on and on. A third of those patients are actually coming from the ear, from the vestibular system itself. So stat number 2 up here is pretty interesting in the United States, and it's very similar statistically in Europe and Australia and throughout the world. But our stats here in the States are 35% of people age 40 and above, which for us is about 60 million Americans, have experienced some type of vestibular dysfunction. So that's pretty wild to think how prevalent it actually is. And then with children, so when we're talking about the pediatric population, 1 in 20 kids in the United States are going to have dizziness or balance problems. So this is a pretty good rendition of what a lot of patients, will describe as dizziness, or what their symptoms are. So again, it doesn't have to be a true spinning or a vertiginous bout or experience, a bobbing sensation. So, what does all this mean, and why are you guys actually here today? And I think the simple answer to it is, we want solutions. We want to know what the next options are and how do we provide relief. So let's get into a little bit of the science, and we're going to kind of high level a lot of this. But one of the most important things to understand when we first get into the diagnostic testing is, are we looking at something that has to do with the central system? So when we're looking at the actual kind of the scary stuff, the brain stem, and the way the brain is processing information, or are we looking at something that is peripheral, meaning that it's outside the brain and the brain stem? And in particular, when we're going through this discussion today, it's going to be how the vestibular system is involved. So before we take a little bit of a deeper dive, I wanted to just break down the ear, and we'll get to a schematic in a minute. But the ear has 2 parts to it. So there's going to be the hearing part of the ear, which most of us associate with the ear itself, and then the actual balance part of the ear. So the balance part of the ear is what we keep referencing, or what I keep alluding to, as the vestibular system. So it will start to make a lot more sense. The purpose of this kind of meeting of the minds here is not to take a deep dive into the anatomy and physiology, but really the functionality and the fix of all of this. So really differentiating between central and peripheral dizziness can be really challenging. So going back to that step one really is to rule out anything scary, any central causes. This is going to be your strokes, any type of TBI. So neurology is involved very heavily. Same with cardiology, making sure that we're not dealing with a situation that could potentially be life-threatening. So that's going to be the first stop for a lot of patients, is to be medically evaluated and any type of those scary etiologies ruled out. The second step is really going to be to determine if it is peripheral. So really looking at what the functional applications of the system are, and if there is dysfunction in one or even more of the peripheral system. So we'll get into a little bit of trivia. So when we start speaking about the peripheral vestibular system, just kind of think in your heads here, but I think this is super interesting, and this is going to really kind of speak to a lot more of the discussions we have throughout the course of the day. But does anybody know the major sensory organs that are in the vestibular system? So we don't have to go through, the names of them, but how many end organs are in the vestibular system? So there's actually 10, which is pretty fascinating. And you're going to hear a lot of discussion about why all 10 of those end organs need to be evaluated. But we have 5 on the right side and 5 on the left side. So let's break this down, because 10 total major sensory organs are going to be making up the vestibular system. So there's 3 semicircular canals. So we all have these in our ears. They look like little loops on a roller coaster. And those 3 canals are responsible for giving us the orientation of where we are in space, kind of the angular and linear acceleration, and then just overall sensation to gravity. So these end organs are very, very important because you could be seated and moving your head up and down, and the signal that's coming from these vestibular end organs is giving our body the input it needs. There is significant involvement in how these little end organs interact and send a signal for our overall balance. So they make a very big wave with regard to our equilibrium, our overall balance, our posture, and then even keeping our head upright, even as we're kind of moving our head around or bending up and down. So if we dive a little bit deeper, I think this is a really cool schematic. Basically, it's telling us, or kind of breaking down, how complicated the balance system really is. So if we think of the vestibular system as like a little GPS, or basically telling our body where we are on a map, it's really important to see how the brain integrates all of that. So the brain is taking input from a lot of different sources. And so the vestibular system is one of them. The input from the eyes, the vision system, the joint, the position, and the actual proprioceptive input from our muscles, control of our motor skills, and our overall posture all goes together. So there's basically 3 reflexes that are working seamlessly in the background. The first one is that reflex between the ear, the eye, the brain. So that's the vestibular ocular reflex. And it really does help with that gaze stabilization with head movement, and helps the eyes compensate. So when they're moving in different positions, when the head is moving in different positions, the eyes are correcting for that movement. The second one is going to be the vestibular spinal reflex. And that one really is responsible for the motor control and then just overall postural support. And then the final one is going to be responsible for actual kind of neck stability and overall head stabilization and position in space. So the brain's taking all of this in real time and processing it pretty seamlessly when we feel well. So I think what's really kind of one of the biggest questions we get from a lot of patients is, how do you even know that it's the vestibular system? How do you even know kind of what we're looking at? Because it is so complicated. There's so many different pieces of it. How do we know that it's not the heart? How do we know that it's not the brain? How do we know that we're specifically honing in on those 10 end organs? So really, it's pretty black and white when we look at things from an objective standpoint. Science and technology have come light years. Even in the last 10 years, we really are able to take the guesswork out of a lot of this. And so you'll see as we get into some of the more complicated and comprehensive talks throughout the day, this is not it's not guesswork. There's no magic to this. It's black and white science with a lot of objective data and a lot of norms that we use worldwide, that all of us are using to make sure we know what the end organs are doing and what they're not doing. So clinically, when you're going into a clinic, there should be 2 kind of wheelhouses with regard to the discussion that you're having with your clinician. So the first one should be subjectively how you're feeling. So what did happen when the onset of this occurred? What is your case history? Was there a cause of it? What does the duration of your symptoms look like? How often is it happening? How severe is it happening? Are there triggers? What makes it better? It should be a very comprehensive discussion. It shouldn't take 5 minutes. It shouldn't take 15 minutes. It should be pretty comprehensive in the sense that you feel you're able to answer all of the questions that were placed on a lot of the questionnaires, and that you're able to articulate your story in its capacity. And it could take a long time so that the clinician has a very good idea of what we're looking at. Now, from an objective standpoint, when we're specifically looking at the ear, so the vestibular system, the tests need to be robust in the sense that the clinician needs to understand with certainty what the system is doing and what those 10 end organs are doing. Now, previously, and when we speak with clinicians who are not in this space all the time, most patients will say, well, they either did, gave patients home epilepsy maneuvers to try at home, or Brandt Durafs to see if that helps, or maybe the patient Googled, or looked up on YouTube some videos, tried some exercises. It's really, throwing a dart with your eyes closed at a target. You might hit it, you might get it right, but at the same time, there is a big, big margin of error. So we take the guesswork out of all of this, really going beyond, trying to see what works or giving some global exercises to see if it helps, and getting to the crux of what's really happening. So previously, I'm going to kind of go backwards forward, because previously, looking at G, so kind of going through my slide here, G is actually going to be what most people associate with balance testing or comprehensive balance testing. It's called a VNG. So it's the video nystagmography, and it's actually looking at, it's a sequence of tests that it's a battery that we're looking at eye movement, we're looking at the actual body positions, and we're putting all of those puzzle pieces together to see how the system is processing input. It's a good battery. It's been used for a very long time, but it is absolutely a sliver of the pie when we're looking at the system comprehensively. So from an overall kind of global standpoint, we see a lot of patients that come in and say, months and months and years ago, I had a VNG and it was normal and I was told to live with this, and that's all we can do. Maybe that's all we could do 30 years ago, 50 years ago, maybe. It's not the case now. So having a normal VNG does not mean that your balance system is normal. It does not mean that the vestibular end organs are functioning in their full capacity. So now we have tests that look at all 10 end organs, and we know that there's different etiologies or causes of dizziness that will affect different parts of the ear. And so again, just thinking through what the anatomy is, if different parts of the ear are responsible for different sensations, a patient who comes in, complaining of vertigo where they're spinning might not have the same diagnostic abnormalities that a patient who says that they feel like they're rocking and swaying all the time might have. And so using the right tests to figure out what's going on with the system is really, really important. So when we get in and we're looking at the vestibular kind of diagnostic story, we want to hear what patients are noticing, but we're kind of very quickly triaging the patient. What tests are they going to need to rule out the part of the ear we're suspecting is causing the problem, or rule in the asymmetry or the weakness that we're suspecting? So it's really, really important to have the tools at your disposal. That's why comprehensive vestibular labs are very, very important. Dabbling in dizziness, or clinics that kind of do it on the side, where it's sort of like a side hustle, where they'll see you, they'll do it, but they don't comprehensively evaluate or have the right tools. It might work for some patients, it just doesn't work for most. And so I'm going to go through the battery here, but the first test is a comprehensive rotational chair. There's quite a few rotational chairs used worldwide. The rotational chair that we use clinically is it's called an eye portal. And the reason we really like this piece of equipment is because of the sophistication of the actual camera, and then the actual frequencies and capability of movement of the chair. And so that's really important, because the balance system is super complicated. It moves very slow and it moves very, very quick. And so whether we're working with professional athletes that have very, very quick reaction times, and their system it has different norms than your average person, walking down the street, it's important to be able to evaluate them at very high or super thresholds. One of the other tests that we use clinically is going to be VEMP testing. And so a comprehensive clinic is going to have access to VEMP testing, which is going to be looking at specifically the otoliths, or a part of the ear that's responsible for that gravitational pull and linear acceleration. The other pieces of the puzzle are going to be looking specifically at Meniere's or changes in the actual composition of the ear and the signal that's coming from different parts of the ear. So there's testing called an ECOG, and then there's additional testing called auditory brainstem response testing. So these need to be included in the vestibular lab's ability, or the vestibular lab themselves needs to have access, or that clinician needs to know where these tests are available, so that if they are deemed necessary, that you're able to dig into them and really allow your physician and your clinicians that are working with you an idea very definitively of what the system is doing. Diagnostic testing, as far as audiological testing, is going to be referring to the actual hearing part of the ear. So looking in the ear itself, looking at the middle ear cavity itself, looking at how the actual nerve with regard to hearing and processing of that sound is occurring is important, because of how the balance end organs and the auditory organs basically live in the same space or same vicinity, neighborhood. And then, so that piece of it is going to be an important piece of the puzzle. Going back to the balance, so the last couple pieces of the balance puzzle with regard to diagnostic testing are going to be computerized dynamic posturography, which we call, we tell our patients it's like the cliff notes of the balance testing. So it's looking at, from a functional standpoint, how you're standing, and then how your brain is taking in the muscle input, the visual input, and then the signal coming from the ear. So those are really, really important pieces. And then the last one on here is a clinic favorite, just because it's pretty simple for patients to tolerate. It's going to be video head impulse testing. It's a really, really lightweight set of goggles, very, very tiny, very quick head movements, and we're actually taking calculations of the eye movement. And so a lot of clinics, this is one of our newer pieces of technology for a lot of clinics, just because we're able to do a lot of the testing and evaluate the system when it's working without making patients feel ill most of the time, which you might have heard with like the VNG during caloric testing, where they're putting, the water or the air in your ears. So long story short, I know this was a long slide, but it's an important slide, because what we see a lot of times is this piece of the puzzle just kind of like goes up in smoke. You get a VNG or you go to an urgent care and you're kind of told, I don't know what it is, it's probably vertigo, good luck. You can't cut out this stage of it. And this stage of it is so comprehensive and needs to be very robust. And if it's not done with efficiency and certainty, patients are suffering for weeks, months, and years. So this is my soapbox. I will spend a couple more seconds on this, because if the clinicians, and again, there's different specialists all throughout the world, there's teams of physicians, there's teams of audiologists, and different clinicians that are doing these comprehensive tests. These are the lifeline for patients. And this is the most important thing, because this piece of the puzzle tees up the actual treatment. What kind of treatment are you going to need? Is the ear involved or not? Or do you need to be seen by another specialist and pull in another group of specialists that are going to be able to help in that treatment plan? So these are some really cool pictures of the diagnostic tests. And so I think it's really important to understand how sophisticated a lot of these pieces of equipment are and how specific the actual calculations need to be. And so again, the eyes are actually the window to the vestibular system. And so a lot of the testing is done through cameras. So patients will be seated a majority of the time and moving some of the time. And we're looking at the eye movements and looking how the eyes actually move under these camera lenses. And so this test, kind of to the left of the screen, is going to be very common for a lot of patients. This is the VNG testing, where you're laying down and you're looking at dots and you're moving your head in different positions. Versus the middle is going to be rotational chair testing, where you're kind of snuggled in. We always tell patients this chair has a lot bigger bark than bite. It's not as scary as it looks. You're really tucked in and secured for a reason, so you're not shifting around or moving. Your body stays in one position as the chair rotates very slowly and very seamlessly. But we're taking eye recordings. We're looking at how the eye is actually moving. And so it's really important to look at the system not only statically, where it's just laying there and resting, but also dynamically. What is it doing when it's working? Because if we're just looking at the system static, where we're looking at, like a V&G battery, that's not the real world. If you're moving around and you're saying you're having difficulty when you're riding in a car, or you're going to get your kids from school walking down the hallways, or you're on the field during football practice, that doesn't translate until you actually task the system and make it work. So that's really important to look at the system dynamically and then, statically. The top right screen is going to be the video head impulse testing. So again, the camera's a lot different. It's really tiny. The head movement's very rapid. It's very quick, but it's usually a patient favorite too, because it's pretty simple. It's pretty seamless. The rest of the testing here is going to get into a few. So I'll go left to right again. So to the left, there are multiple computerized dynamic posturography platforms now. This one is an older version that's used to basically visually challenge the system, and then you're on a force plate or like a moving floor. And there are advanced versions now that also integrate virtual reality to really get a good snapshot of how your system is processing and taking in visual information, and then how that actually makes sense with how your body moves and sways. The top one with the little button is actually looking at kind of subjective vertical upright, and that is going to be a subjective test of how you perceive things to be in the environment. So again, it's looking at the otoliths, or the part of the ear that's responsible for that gravitational pull. The bottom screen to the right is going to be the actual vent testing, and additionally any type of electrophysiological testing. So anytime we're using electrodes on you, or anytime that we're actually trying to pick up frequencies coming from the system. They're pretty simple to do. This one particularly is looking at the vent testing. So again, it's sort of like getting a bad facial, where you'll get scrubbed, you'll get electrodes on, and then you basically are just going to rest, and we're going to take the calculations from the system. The top right is just a really cool picture. We think it's pretty cool, but your eyes are going to be on the screen when we're doing a lot of the rotational chair testing. So we've got these huge kind of snapshots of what your eyeballs are doing on the screen, and it's very, very detailed and very specific. It's taking tracings of your eye movements, and then it's actually putting it into the software and making calculations in real time. And so it's extremely calculated. And again, there shouldn't be any guesswork. You either have a vestibulopathy or you do not. The system is either functioning at thresholds that are normal or compared to normative data or not. And again, this is not a general rule. This does not apply to every single person in every situation, but there's a lot that goes into this that's well beyond the V&G. So there's a lot that we can actually get from all of this data. And the way a lot of clinics work with regard to kind of the handoff of patients should be pretty seamless. So patients where we see have the most difficulty are bounced in between different specialists, and there's not this continuum of care. And so patients who are medically cleared on the front end receive diagnostic testing comprehensively in the middle, and then are transitioned to therapeutic application that takes those thresholds from the diagnostic testing is where it all comes together. To skip one or to go in the reverse order is not going to work. Again, just getting, handout exercises or just skipping to a rehabilitation program, it works for some, but for most patients, understanding what the right ear is doing, what the left ear is doing, what the etiology, the actual cause of this is, what the current functional application of the system is, and then moving from that point is where this all kind of gets strung together. So looking at all of this and going through all those tests and then sitting through all of the diagnostic testing, if necessary, should give us a really good snapshot of what's happening. So not every patient needs every test. And again, it could be very quick where the patient's coming in, they're going through repositioning maneuvers and they move on with their lives, or it could be very comprehensive. And so here's kind of a rundown of, a lot of different pieces of the vestibular puzzle. You're going to get a lot on this today. And so I just wanted to give an overview, because the physicians and the clinicians that are presenting on this, you're going to get some really good meat from the presentations. So the first one is going to be BPPV. So that is positional vertigo, or benign positional vertigo. The second one is going to be labyrinthitis, or vestibular neuritis, chronic versus acute vestibulopathy, migraine-associated vertigo, or vestibular migraine, visual vertigo or visual disturbance, Debarquement syndrome, dizziness that can be age-related or imbalance, and even superior canal dehiscence syndrome, or a paralymphatic fistula. So just a few, I'm going to pick kind of some of these top disorders and give you a little bit of an overview. And you're going to take a deep dive later in the actual day, so that you can kind of understand what this looks like. But benign positional vertigo, or BPPV, you've probably heard before. It's been described as rocks in your head or crystals. And the long and short of it is that there's literally rocks in your head. We all have them. You want them. They're supposed to be there, but they're not supposed to move out of the position they're designed to live in. And so when they come out of the position they're supposed to be in, they cause a very, very intense but brief bout of vertigo. So it's like a true spinning sensation. It's lasting usually less than a minute. So usually it's going to be seconds up to a minute, and then the symptoms stop. And so literally the symptoms stop when that little calcium deposit, or the rock, or the actual crystal moves back to kind of a resting position. So I'm not going to get too into this, but you're going to get a whole talk on this today. That's extremely interesting. This type of vertigo sort of is like a wave a magic wand and goes away kind of vertigo for most patients. So upwards of 85% of patients will get a treatment or two and move on with their lives. So it is a pretty simple treatment for a lot of patients. And same diagnostically, it's pretty easy to see in patients. The eyes move a really funny way, so you can see on the schematic. They don't just move side to side or up and down. If you're dealing with the back canal, so the bottom canal is called the posterior canal, the eyes torque. They kind of move in this really funny torsional fashion. So for us, what we're looking at is nystagmus. We're looking at eye movement. All of our testing is done under goggles. It's really important for our clinic and for a lot of clinics worldwide to use goggles, because we can figure out which canal, right or left, up or down, or even the side canal involvement. And then it helps us with the treatment too. The fun fact that I wanted to put on here is that residual symptoms after BPPV can actually last for months. And so we're going to have a pretty interesting talk on this later. But it wouldn't be the spinning that's happening any longer for patients. It would be any imbalance, unsteadiness, disequilibrium that they still are having after the treatment of the spinning. So the other one that we're going to kind of touch on is going to be vestibular neuritis, or labyrinthitis. So the main difference with this is really going to be, is the hearing affected or not? And so with this, a virus basically enters the system. And with labyrinthitis, you're going to have a change in hearing and a change in balance. And so having a comprehensive audiological eval, or looking at the hearing, is going to be important. Because sometimes patients are coming in and they say, it feels really full in my ear, or it feels like maybe the right ear hears differently than the other. Taking the guesswork out, is it fullness in the ear, or is it change in hearing of the ear, is going to be really important. The treatment for this is really going to be medical management, and it's very important that the physician is involved with regard to medical management of the patient initially. In most patients, a couple of weeks, they move on with their lives and they're fine. Sometimes they will need medical intervention that's going to include vestibular rehabilitation therapy, in addition to any type of steroid or antibiotic regimen that the physician is going to recommend. But for the most part, most patients will get it. It's pretty nasty for, a couple of days or a couple of weeks, and then, they're completely resolved. little fun fact on here again is going to be cold and flu season is actually the busiest time of the year for labyrinthitis and then vestibular neuritis. So Meniere's disease is going to be another one that I just wanted to touch on. Again, you will get a talk, but some of the hallmarks of this I think are really important to understand, because there are so many patients that will say, well, I have vertigo. Okay, what does that mean? Or I have Meniere's disease. I was told I have Meniere's disease. And so when you go in and actually try to understand what that means, and we go through, okay, do you have pretty intense bouts or drop attacks of vertigo that are lasting for hours at a time? Do you have roaring tinnitus where your ears really just kind of sound like somebody turned on a fan, or it sounds like, just a whole jet engine kind of turns on? Do you have fullness in your ear or ears where you feel like it's literally full of liquid or fluid, or you need to pop your ears? And do you have fluctuating hearing loss? Is your hearing coming and going? Is it getting worse over time? So those all need to come together. Being evaluated by a neuro-otologist, or even a physician in general that's going to be able to just allow you to kind of say what your symptoms are and kind of go through the boxes. Is it the vertigo? Is it the tinnitus? Is it the fullness in the ear? And is it the actual fluctuations that are documented over time of hearing loss? If it's one or none of those, it's not Meniere's. And so that's why it's important, again, to get the diagnostic testing. The ECOG testing and the audiological testing are very important for this patient population. So another fun fact is going to be Vincent van Gogh actually suffered from Meniere's. So migraine-associated vertigo is going to be, this is such an interesting, very, very interesting etiology, and there's so much work going into this right now with regard to research and treatment and how these patients are managed. So migraine in general is one of the most debilitating chronic conditions in the United States, and that's pretty similar throughout the world. And so what I think is one of the most important things to really note is that 40% of patients with migraine will have a vestibular component affecting their balance or dizziness. So that's really important to understand, because a lot of times when you say migraine, sometimes patients will say, well, I don't have headaches. I don't have headaches. Understanding what migraine-associated vertigo is and what it's not is very important. And so again, you're going to get a very comprehensive talk on this, but this is a very exciting piece of the puzzle as far as research and treatment that's coming out, because patients are starting to really understand what this management looks like and what it looks like to be managed medically, from a medication standpoint, from a supplement standpoint, but also dietary, what it looks like to be managed, from a trigger identification, and working with dietitians that are able to really go through and really make sense of anti-inflammatory diets and what specifically the triggers are to that specific person, which is really important. So the diagnostic criteria for migraine patients is, going to be a family history. Most patients have motion intolerance, even in childhood. They're presenting with vestibular symptoms, and there's a whole kind of checklist or tick list that's followed, when you're in front of the right specialist who understands what migraine-associated vertigo is. And if they don't understand it, getting you to the right specialist that's able to really go through and manage that condition for you. So with all of that being said, you'll hear, or maybe even you just want a magic pill. You want this to go away. You want it to be better. You just want things to kind of go back to how they were before this all started. And so initially, especially in the States, when patients are going into urgent care, they are screened for stroke, making sure that they don't have any stroke. Usually they're getting imaging that's going to include a CT scan or an MRI. And then if that's fine, they're kind of sent on their way. And so, not to keep things, too global, but for the most part, making sure that there's not anything medically that needs to be, evaluated quickly or anything that's life-threatening. And if it's not, you know, here, take a meclizine or take an antivert or take something that's going to make the symptoms go away temporarily. And so what works very, very short term, and the use and the design of a lot of these vestibular suppressants is short term. You're supposed to use them short term. They're supposed to help short term. And so they're not meant to be used for weeks and weeks, months and months, years and years, decades and decades. It doesn't work that way. Your system doesn't, it doesn't happen with regard to recovery that way. So the brain can't fix what it can't see. It can't habituate. It can't adapt. It can't compensate unless it's getting and receiving the error signal itself. And so if you're taking the meclizine or you're taking the anti-motion or basically a vestibular suppressant, an anti-vestibular medication, it's like a spring. You're pressing down on a spring long term. And so one of the biggest things, once that diagnostic testing is done, is to get the rehabilitation going. And so that's really working with the right specialist, whether it's the vestibular specialist, you know, that really knows how to do this, or finding the vestibular specialist in your area that knows how to do this is going to be very, very important. There's going to be a talk later on the time frame of all of this and why that is so important. You don't want to sit around for weeks and see what happens. You don't want to sit around for months, let alone years. Your system needs to be just kind of guided and moved in the right direction so that the rehabilitation process can happen. So we've got standard vestibular rehab therapy, just the 101 of all of this, is going to be kind of tried and true. It's very, very effective. It works a majority of the time for patients, as long as it's done consistently. And it's usually ran through three kind of systematic ways of introducing the exercises. So it's going to be adaptation exercises that are designed to address the symptoms of gaze instability and with head movement. And the point is really helping your brain adapt to seeking these visual targets within, you know, the real world, and helping your brain starting to integrate those processes again properly. The next sequence is going to be substitution exercises. So they're really designed to address symptoms where the impairment of the balance or the actual system itself is no longer capable of using all cylinders. And so it's really helping the brain seek new input and use new input. So it's either going to be, you know, reweighting the system from a visual standpoint or a sensory standpoint, because you're not getting what you need from a stimulation standpoint coming from the ear. And then the third one on here is going to be habituation exercises. So they're really designed to provide temporary symptoms. So you will be triggered when you do these exercises. So again, trying to provide like a little mirror to the balance system. So helping the brain see when it needs to fix and see what it needs to actually work through and process. Because the brain is very plastic. It wants to fix itself. It's just these sequence of exercises ramp up just enough, again, based on the thresholds that you were able to tolerate or were able to tolerate initially, and then building from that, sort of like if you're going up a stairwell, you know, you want to build and then you want to plateau, build, plateau, build, plateau. What happens a lot of times is if you are, you know, playing Dr. Google and you go online and you just find a sequence of adaptation exercises or substitution or habituation exercises, and you haven't been evaluated by a vestibular therapist and you're not working with a therapist to go through and really basically know when to gas and break the system. When do you push the system so that it's growing, it's learning, it's changing, it's getting stronger? And then when do you gas it where you need to pause, relax, and allow the system time to rest and recover? And so working with a specialist, it's really, really important, because that's the end game, making this efficient and effective so that you can move through as quickly as possible. So here's just a couple quick little snapshots of patients who are performing those substitution, adaptation, and habituation exercises. Pretty simple. You'll find them. There's all kinds of books and all kinds of resources. But from a physical therapy standpoint, from an occupational therapy standpoint, and a lot of other specialties that are working in this wheelhouse, they're pretty classic and pretty standard exercises. When you move from one to the next, it's based on a lot of your subjective input and then objective data, which you're able to tolerate. There are a lot of clinics that are continually monitoring, so it's important, you know, as you move from one system or one sequence of exercises to the next, what is the graduation look like? Does it mean that you're scoring lower on certain questionnaires, the DHI, for example? Are you starting to present with different input with regard to your SVV or SVH input? Are you scoring higher on your computerized dynamic posturography? What does this look like as the process is moved through? And each specialty will be using different kind of rubrics to move patients through with regard to next steps and continued improvement. So the next one on here is really going to be how technology is moving a lot of this forward. So instead of, holding a card in front of you or putting your thumb in front of you, which is a very viable and a very helpful option, technology is advancing significantly. So whether it's clinically or with home use, patients are using a lot of optokinetic stimulation. They're using a lot of virtual reality application. There are a lot of companies now that we're using that are actually specific for vestibular rehabilitation. And so it doesn't mean that we're putting VR goggles on and helping you, get used to riding a roller coaster and trying to make you sick while you're watching, videos through the VR. That's not it. It's literally providing the bridge between where your system is functioning and what your system is functioning and the capability of your system's functionality and where it needs to be in the real world. So the real world has tons of sizes and shapes and colors and thresholds and lights that you're constantly being exposed to. But through a lot of the virtual reality rehabilitation programs, your system in the VR is very slowly and very systematically being exposed to a little bit more each time, so that you're actually able to bridge the gap between where you were, where you need to be, and the VR does a pretty phenomenal job of getting patients there. And then a lot of the rotational chairs and a lot of the posturography equipments are being used therapeutically too. So patients are not only dynamically, in there with their movement or in there during the diagnostic testing, but then again being worked through and helping the system habituate along the way so that those thresholds are increased and they're getting improvement overall session over session. The home applications should duplicate a lot of what's happening clinically. This is just a couple quick little snapshots of some of the virtual reality that we've created in our clinic. It should be fun and simple and crisp and clear. And so a lot of it is done through optokinetic stimulation. Some of it is done through a lot of visual desensitization. And a lot of it's done through gaze stabilization, the simple stuff that we're doing even with thumb movement. So it's really important for patients to understand that this is a process and there's a very systematic way that this process and the brain compensates, which is important. So kind of the take home is going to be that dizziness affects all of us at a certain point, whether it's directly or indirectly through a family member or friend. And so it doesn't matter how rich and famous you are. It doesn't matter kind of how high level your functioning is or how low level or slow or kind of sedentary your overall daily tasks might be, that this is something that is extremely debilitating when it hits, but there are science and solutions that are at the ready. And so that's really what we're excited to present today and kind of move through today. One of the most important things, just a quick little synopsis, you're going to get more of this, but it's going to be how on earth do you find a vestibular specialist that is going to know that this is more than the V&G? This is not, circa 1970. This is more than the V&G, and we are able to test more of the system in a very comprehensive and very specific way. So you want to be working with a specialist that specializes in dizziness. And so if the first stop is working with your primary care doctor who does not specialize in dizziness, asking him or her who in the area does specialize in dizziness. And it should be a day in and a day out dizziness specialty. It shouldn't be dabbling. And again, it really shouldn't be a side hustle. It shouldn't be something that you do because you kind of remember how to do it, or maybe, you want to get into it. You got to dive into this because there's too much at stake with regard to time frame and and loss of quality of overall just life. So it's also important to have advanced equipment to really be able to evaluate the entire balance system. Using things that we did, again, kind of going back to that 1970, time frame, we've come light years ahead. There's no reason why we're not able to advance and look at the system comprehensively. And if the clinic that you're at does not have capability to do it, who in your area does? Because there are very comprehensive balance clinics throughout the world that have a passion for this and a real knowledge and a real investment, not only financially, but in the overall outcome of patients. So finding those people who not only put the money down to make this right from an actual, diagnostic equipment standpoint, but understanding how you leverage that for patients and how you help the overall outcome, which is getting people better. Working in a team is huge. Not having a one-stop shop where, if it's not the ear, I don't know, good luck with that. Who are the specialists in the area? If there is some neurological concerns, where is the neurologist that you're going to be working with, or who are they? If there's a cardiologist that needs to be involved, if there's a dietitian that needs to be involved, an occupational therapist, your physical therapist, all of this needs to go together. And it would be very, very unlikely. I've never heard of one person that can do all of that. So it's really understanding, is your specialist, do they work with part of a team? And if they are collaborating within their community to make sure that the patient is getting what they need from beginning to end. Another important thing, and you have to do a little bit of digging on this usually, but really understanding, even when you're speaking with a lot of the support staff, is that professional active in associations that are continuing their knowledge, and are they current in, their research and treatment? And I think it's a right as a patient to understand, are they staying current? Because technology changes very rapidly, and the treatment protocols and processes change very rapidly. So just to claim that you're in this space, or just to, work with patients that you think you can help with dizziness, isn't best practices for the patient or for the professionals who are really, kind of helping gear and steer all of, this funnel towards one direction. And so the other thing, and the final thing, is going to be explaining your treatment options and how it works. There's a lot of different ways that this can be applied. Not all patients like virtual reality. Not all patients like, thumb movements that they're going to be doing for gaze stabilization, based on home printouts. Not all patients want to follow up with a dietitian. Not all patients want to follow up with, lifestyle modifications or going through what potential triggers could be. So understanding what the recommendations are, and then what is going to be applied or be applicable to your specific situation. So the take home is really going to be, if you're just looking at a small picture, right? So the picture to the left is going to be a tiny little snapshot. If I'm just looking at the VNG testing from a diagnostic standpoint, or I'm just talking to the patient for 3 to 5 minutes about their dizziness and trying to really quickly understand what's happening, am I getting a full picture? And so, I don't know, I would have guessed maybe it's like a little boy's haircut, or like the top of a little boy's head. With the long and short, if you take a step back and you start to look at the big picture, there can be so much more involved. And so not just doing the VNG, not just doing a quick get up and go, you have to look at the patient comprehensively to make sense of all of this. So with that being said, I am really excited to kick this off. I think it's going to be a very informative day. You can always reach out to us if you have any questions. Our info's at the bottom. Our email is info@dizzyandvertigo.com, or on our website at dizzyandvertigo.com. And
wonderful, wonderful. Are we live, Q?
You're live.
Awesome. Well, it looks like, Amy, you've joined us. Brooke might be coming back from there. Amy, if you want to field one of these questions that we're taking, Laura asked, are there any barriers to treating vertigo when a woman is pregnant?
Yeah, so obviously, when a woman is pregnant, you always want to be extra careful with any kind of treatment and management that you provide. However, as long as you're very kind of, it's a two-way street. So it's not a clinician delivering the treatment program and that's the end of it. It's very important that the patient and the clinician work together to make sure that any kind of steps forward or any kind of rehab is not too much and doesn't overwhelm the system. I think it's also important that if there is a pregnancy involved, that there is some sort of medical input as well, just to kind of oversee it as a whole, keep an eye on the cardiovascular system and any other complications that may arise because of the pregnancy and not necessarily because of the dizziness.
Gotcha. Makes sense. Brooke, here's a question from Debbie, who said her telltale vertigo symptoms have changed from the spinning sensation to a more bouncing sensation. Is it common for vertigo symptoms to change over time?
Yeah, Debbie, thanks for the question. So I think one of the biggest things that we want to get into is making sure that we're not specifically answering specific medical advice, but that understanding what your dizziness or the etiology of your dizziness is initially. Again, if we go back to those 10 end organs in the ear, the spinning sensation that can originate from a certain type of dizziness versus, kind of a rocking or a bobbing sensation, they typically come from different parts of the ear. And so working with the right specialist to understand what the cause or that etiology is really important. And then as the system progresses and the system strengthens and starts to compensate, you can start to feel different sensations along the way.
Makes sense. There's a question here from Monica, who was wondering, how would you suggest tracking and identifying one's own triggers over time? And then once you know those triggers, I guess, what's the best course of action? Is it avoiding them, or is it, sensitizing yourself to them?
So I think, obviously tracking them is really important because you can kind of feel from day to day, it can be pretty overwhelming. So we always ask, to track your symptoms so that we understand if there are stress triggers, if there are fatigue triggers, if there's food triggers, hormonal triggers. There's a lot that can go into it. And so working with the right specialist to identify those patterns is very important. And then moving through with your treatment specialist, that can be, become a part of the actual treatment protocol moving forward.
Gotcha. This one comes from April. She, this can be kind of a more generalized one, but for people who have multiple vertigo diagnoses, say vestibular neuritis and vestibular migraine, what's the process for distinguishing what's causing which issues if they have multiple diagnoses?
So Amy, do you want that one or do you want?
No, I can go.
Okay. Yeah.
Okay. So I think that's where the really comprehensive testing becomes very important. So if you've been given multiple diagnoses and you maybe haven't had the comprehensive, so if you've just had VNG, that's really important for you to have as many investigations that are available to you. After that, once there's a bit more of a bigger picture of what's going on, I suppose dealing with your symptoms is kind of how we would build the treatment. So for example, you might have patients with I don't know, a peripheral vestibulopathy that have a visual component to their symptoms, or you might have patient B who has the same vestibulopathy, but they have no visual component to their symptoms. So then that's when you're dealing with the symptoms and working with them and making it very patient specific.
Makes sense. Chris was wondering, when vertigo is gone, how can you tell if there's still damage to your vestibular system? So after treatment has been finished, how do you know if there's still damage?
Yeah, I think that goes back to kind of the objective and subjective pieces. So we always look subjectively. There's a lot of questionnaires that are used, going back and making sure that subjectively that you're feeling better, that the questionnaires they should pull within normative range. But there's quite a few different studies right now showing that some of the testing will actually show normative data when you go back and look at it after the fact. So working with the right clinician to understand, what was initially abnormal from an objective standpoint during the testing. And then if you're interested, a lot of clinicians will do comparative testing. So more of like a graduation when you're done with your treatment, going back and comparing apples to apples and kind of bookending the treatment process.
Gotcha. One more question here, and then we'll take a brief break before the next one. Patricia is wondering, and not sure if there are any answers to this, but has anyone done any research into dry needling sessions for stopping chronic symptoms of vestibular migraine?
I mean, maybe we could have a little publication search during the break and answer that one after the break. How about that?
That's a great idea, Amy. All right, Q, you want to put us into a break, and then we'll reconvene for the next one, which is going to be BPPV.
Thanks, guys.
Yep.
Dr. Brooke Pierce.
Hi, guys.
And Amy.
Hello.
We are now back. It is Vertigo Day.
Yay.
How was your break? Did you enjoy your break?
It was great.
We have a few questions. We have a few questions in the comments, and then we'll get into Professor Alfarghal's presentation. The first question that I thought was pretty fascinating was talking about the diets for people that are diagnosed with vertigo and dizziness.
Yeah.
What are there any particular dietary recommendations for people that want to be vegetarian or that are vegetarians and also have vertigo or dizziness? Question for either one of you all.
So I'll jump in, and I know Amy's got a wealth of knowledge on this. So I think that kind of chatting when the physicians kind of pop on in just a few, but making sure that you're working with your physician and or a registered dietitian, because there's quite a few different things that, you know, being deficient in certain vitamins can cause dizziness, whether it's B12 or vitamin D. So making sure that, you know, you're working with your physician with an accurate blood panel, and then working within the parameters with whatever dietary kind of limitations or restrictions that you have is really important.
Got it. Now, Professor Alfarghal, I'm going to add him to the stream really quick.
There he is.
Joining us.
Hey.
Hello.
All right. Now, for the people that don't know, he's going to be talking about BPPV. And just to give a quick intro, 30-second intro about Professor Alfarghal and where he comes from. Amy, would you mind taking it away there?
Of course, I'd be honored. So Professor Alfarghal Mohamad is from Jeddah, and he has been doing a lot of work over the last couple of years disseminating information to clinicians all across Egypt, Middle East. That's how it started, but it has now grown into this huge network where he has been sharing his knowledge. He's trained all around the world. He's trained here in the UK. He's trained with people in the US. So he is just a wealth of knowledge. And thank you for joining us today.
Professor Alfarghal, can you hear us? Don't.
He's getting ready. He's getting
ready. He's getting
ready to go.
All righty. All right. Well, with that being said, we're going to go ahead and jump into the presentation. I'm going to start it up on screen. And for anyone that has any questions, you can email us. We'll throw our email up, and you can also leave them in the chat on YouTube. And with that, we'll be back momentarily.
Hello, everybody. Good morning, good afternoon, good evening. It's a great pleasure to be with you today. It's a pleasure to talk to you about benign paroxysmal positional vertigo. Before I proceed with my slides, I wanted to introduce myself to you. My name is Alfarghal Mohamad. I am Egyptian, but I do live and work in Saudi Arabia. I am a medical doctor and at the same time a clinical audiologist. I got the Doctor of Audiology degree from the United States. And I am currently working as a director of Hearing and Balance Clinic at King Abdulaziz Medical City, Jeddah. And at the same time, I am currently the president of the Arab Balance Society. So this is in the left where I work. This is the King Abdulaziz Medical City in Jeddah. And this is on the right, the logo of the Arab Balance Society. So BPV, it points to benign paroxysmal positional vertigo. It is the most common cause of vertigo and dizziness, absolutely in all over the world. Its live prevalence of BPV was reported to be 3.2 in females and 1.6% in males and 2.4% overall. Other names given to this condition are inner ear stones, rocks, crystals, or particles, and sometimes it's called the high shelf vertigo. So in this diagram, it shows the structure of the human ear. The human ear composed of three main parts. The external ear, it's composed of the auricle and the external auditory meatus. And the middle ear, which composed of the eardrum or the tympanic membrane, and a space for usually normally filled with air, and it contains three small tiny ossicles and the eustachian tube. Then the third part is called the inner ear. It's composed of two main sections. One is called the cochlea, which is responsible for hearing, and the other section is called the vestibular system, which is responsible for the balance. In the next, in this image, it better explains the vestibular system. So as you see here, the vestibular system is composed of three semicircular canals. They are bony canals, includes membranous canals, which is filled with fluid named endolymph. And this is the superior semicircular canal. This is the posterior semicircular canal, and this is the horizontal or lateral semicircular canal. They are connected or end to another organ. It's called the utricle. It's a part of the otolith organs, which are the utricle and saccule. This one is called the saccule. But the three semicircular canals, they are open to the utricle. The semicircular canals, they are responsible to feel the head movements, angular head movements, and through their connection to the extraocular eye muscles, they keep the visual image stable while we are moving our heads. So during walking, running, still we can see clearly, no blurring, no slopsia. And the afferent fibers from the semicircular canals, they are connected to two divisions of the vestibular nerve, the superior vestibular nerve and the inferior vestibular nerve. Both of them combine to make the vestibular nerve. The vestibular nerve combined with the auditory nerve coming from the cochlear nerve fibers to make the eighth nerve, which goes to the brain. So here another view to explain the inside structure of the semicircular canals and the otolith organs. So if you see here, if we take a transverse section in one of the semicircular canals, we would see what's called the ampulla. And this is the ampulla of the semicircular canals. It's like a gelatinous mass. It contains hair cells arranged in a special way, and it's floating inside the endolymph fluid within the semicircular canal. So with any kind of head movements, one or more of the semicircular canals, they got stimulated by the fluid movement inside them. And this fluid movements makes them to send signals to the vestibular nerve and to the brain. And the brain analyzes these signals and it perceives the head movements and do the proper adjustments of the eye position to ensure a clear vision. And if we take a cut section in the otolith organ, especially the utricle, we can see here that it's composed of a similar structures, but it's called the macula. And there is some hair cells arranged in a special way. And over the hair cells, there is a cilia, and this cilia embedded in a gelatinous membrane which contains otoconia. So this otoconia is a tiny particles composed of calcium carbonate, and it helps in the sense of gravity. It helps in the sense of linear movement, like movement back, forth, left to right, up and down. So this is the otoconia is a normal part of the vestibular system, but it should be placed and present in the utricle. So whenever it detached from the utricle and migrated to one of the semicircular canals, that starts to create some problems. And this is the main pathophysiology of the benign paroxysmal positional vertigo. This is an image to explain to you that is each semicircular canal is connected to a pair of extraocular eye muscles on the same side of the semicircular canal and on the contralateral side. So with this connection, each semicircular canal, when it gets stimulated or inhibited, it creates some sort of eye movements, which we call it nystagmus. And we cannot see the inner ear by otoscopic examination. We cannot see what's going on, but it's easy to see the effect of stimulation or inhibition of the semicircular canal by just looking to the eye. So each semicircular canal, when it gets excited or it gets inhibited for a reason or another, it creates a specific eye movements more or less in the plane of the semicircular canal. So like, for example, the posterior semicircular canal, when it gets stimulated by, for example, presence of otoconia, it creates upward torsional nystagmus. So the clinician, by watching this kind of nystagmus, he can recognize where is the otoconia, which canal is affected, and which side is affected. So no wonder that is testing for the BPPV is mainly by looking into the eyes of the affected subject. This is to make it more clear what's happening during the BPPV. So this otoconia, which is normally should present only in the otitis organs, in the saccule and in the utricle, to do its function for feeling the gravity and linear acceleration, it sometimes, for some reasons, get detached, and when it get detached, it just migrate into one or more of the semicircular canals. Most commonly, it migrates to the posterior canal because it is the most dependent. When we lie down, it's the most inferior, most dependent. So by the effect of gravity, this otoconia get precipitated mainly in the posterior canal. But also, it sometimes migrate into the horizontal or lateral canal. But very rarely, it's present or migrates to the anterior canal. And this is simply because the anterior canal is in a higher position and its posterior wall is in a direct continuity with the utricle. So even if it happens that some otoconia migrated to the anterior canal, it will self-clear in no time. So that's why it's the most rare type of the semicircular. It's the most rare type of BPPV is to affect the anterior canal. So the most common, it affects the posterior canal. Second common is the horizontal canal, and the least common is the anterior canal. This is a microscopic or electron microscopy image of the otoconia. So it looks like a very small rocks. Sometimes they get amalgamated and they make like a mass. So it causes more symptoms. When they get dispersed all over the canal, the symptoms become less intense. So that's why it's a natural history that it subsides spontaneously over a few weeks. The otoconia can be placed in different locations in the semicircular canal. This is very obvious in the horizontal canal. There is different possibilities. The otoconia can be in the anterior arm or can be in the posterior arm, can be attached to the copula of the semicircular canal, and rarely it can be on the auricular side. So the clinician, by careful examination of the eye of the nystagmus provoked by different positions, he can know where is the otoconia most likely located. So why do BPPV occur? It could occur for no unknown reasons, of unknown cause, idiopathic. And it could occur secondary to another ear disease, such as Meniere's disease, vestibular neuritis, otosclerosis, or after ear surgery. Post-traumatic, if BPV developed 24 to 72 hours following head trauma, we name it post-traumatic BPV. And the head trauma, even the minor ones, such as domestic injuries, skull injuries, dental care, can trigger otocorneal detachment, leading to the development of BPV. Types of BPV. The best classification of types of BPV is based on the affected canal. So as I mentioned before, posterior canal is the most commonly affected canal because it is the most dependent canal. So the gravity pushes the otocornea to be precipitated in the posterior canal. That's why it constitutes 75 to 80% of the cases. And interestingly, it's most likely occurs on the side where the subject is sleep on. So if the subject used to sleep on the right side, so it's there is more opportunity that the BPV develop in the right side. And this makes sense because lying on the right side most of the time will give opportunities that the gravity precipitates the otocornea on this side. And it's known that most of the people all over the world, they sleep on the right side. So it's more common in the right side. Horizontal or lateral canal BPV, it constitutes 15 to 25% of the cases. And the anterior canal, it's the most, it is the least common type of BPV. It's only reported in 1 to 2%. Some more complex forms of BPV can occur, like the multiple canal BPV, either due to bilateral affection of the posterior canal or due to mixed canal affection. It constitutes 6 to 20% of the cases, and it's most common in post-traumatic cases. Diagnosis of BPV, it depends on the history. It's very important. Examination, clinical examination, or office or bedside testing. Then investigations. Fortunately, investigations are only required for atypical or resistant cases of BPV. But the typical cases of BPV can be completely and accurately diagnosed with a bedside testing. So what are the risk factors of BPV? It's known that it's 7 times more common in elderly people. So above 65 years of age, the incidence of BPV increases by 7 times. It's known to be more common in females. And this is maybe because of the probability to have osteoporosis are more common in females. Also migraine, which is another risk factor of BPV, is more common in females. Most common to occur at the sleeping side. That's why it's more common in the right side, as I explained previously. It is 3 times more common in migraine patients than the general population. Osteoporosis and vitamin D deficiency are risk factors for BPV. As we mentioned before, the otocornea is composed of calcium carbonate. So it's in some way related to calcium metabolism. And of course, it would be related to vitamin D, which plays a major role in the calcium metabolism. Prolonged bed rest, like after surgery, major surgery, or in cases where is restriction of lying down to one side, or because of like a fracture, because of like a pain, like some patients, they put a pacemaker on the left side, so they usually cannot lie on the left side because of hemiplegia or something. So people who are prevented or restricted from lying to one side and they have to sleep or lie only on one side, they are at risk of to develop BPV in that side. And also people who have been in a long-term bed rest, like after pelvic fracture or major surgery, they also at risk to develop BPV. Conditions which cause inner ear ischemia, like diminished cerebral perfusion or vertebropassaral insufficiency. The inner ear takes its blood supply from the posterior circulation of the brain. So when this blood flow to the posterior part of the brain got compromised for any reason, definitely the inner ear will be affected, and this effect can lead to detachment of the otoconia from the esophagus. And of course, there is other risk factors, but they are less common. History and symptoms. Usually, BPPV presented by a position or head movement induced intense vertigo, lasting for less than a minute in most of the cases. It might be associated with nausea, vomiting, and sweating. When the lateral canal or horizontal canal BPPV is involved, subjects may complain of mild unsteadiness during walking. Patients sometimes become stressed, anxious, and panic. So, in this slide, I'm sharing with you the 5 positional items from the Dizziness Handicap Inventory published by Jacobson and Newman in 1990. And in our clinical practice, we use these 5 questions to screen the general population for BPPV. So the 5 questions are all related to the positional dizziness or positional symptoms. So the first question is, does looking up increase your dizziness or your problem? That's why it was called high shelf vertigo, because sometimes the symptoms occur when the subject tries to pick an item from a high shelf. So does looking up increase your problem? Do quick movements of your head increase your dizziness or problem? Does turning over in bed increases your problem? Does quick movement of your head increase your problem? Does bending over increase your symptoms or your problem? So those 5 questions, they could be used to screen for the BPPV. So if some of them they have been positive, or the subject answers they do experience dizziness or vertigo in any one of these situations, so that means they are most likely have BPPV. So we can confirm or diagnose the presence of BPPV by what's called Dix-Holpike test. This test was published by Margaret Dix and Charles Holpike long time ago, and it's mainly intended to test for the posterior canal BPPV. And the test is to turn the head 45 degrees to the side, then briskly bring the head in the supine position 30 degrees from the horizontal line, or like 30-degree extension of the head. So in this position, the posterior semicircular canal become vertical relative to the gravity line. And this is will let the otoconia within the posterior semicircular canal move with the gravity, and it start to produce the typical or characteristic vertigo and nystagmus. During the testing, it's always preferred to use infravideo Google tool to record the eye movements and display it into a screen or a monitor with the use of video goggles. But some clinicians, they just do it without goggles, but it's recommended to examine for BPPV with the use of infravideo goggles. So when the head becomes in the 45 degree to the side and 30 degree extension, in this position, the semicircular canal becomes perpendicular to the gravity, and if it contains otoconia, the gravity lets the otoconia move within the endolymph of the posterior semicircular canal until it reaches this neutral point. During that period of movement until it settles, this movement of the endolymph fluid, because of the effect of movement of the otoconia, it leads to excitation of the posterior semicircular canal. This excitation leads to the generation of upbeating torsional nystagmus, which is the typical of posterior canal BPPV. And it usually lasts just for less than 1 minute. Once the otoconia get rest in the new position, the symptoms stop and the nystagmus stop. So I put here some videos just to show you what the clinician would see when there is a positive case for BPPV of the posterior canal. So let's to run the first video. So this is in the right dixal bike. As you see here, there is upbeating and torsional nystagmus. That's abnormal movement of the eyes of the patient. As you see, it's a torsional movement. That's what makes the patient feel the room is spinning or the bed is spinning. Then just in like a 30 seconds, it stops and the symptoms disappear and the nystagmus disappear. Each semicircular canal BPPV generates a specific type of nystagmus. So the video you just saw, it is for a posterior canal BPPV. But when the horizontal canal got affected, it usually generates a horizontal nystagmus. So as you see here, it's a right beating nystagmus. But interestingly, regarding the horizontal canal BPPV, it usually generates nystagmus on the right side and on the left side. So we call it bidirectional, bipositional nystagmus. It's of two types. It can be geotropic or apogeotropic, but simply there is two phases of nystagmus. When you turn the subject's head to the right, it generates right beating or left beating nystagmus. When you bring the head into the opposite side, the nystagmus reverses. So it's either left or right. So when the eyes beat or the nystagmus is directed towards the ground, we call it geotropic. And when it beats far away from the ground, we call it apogeotropic. So the clinician always look for the nystagmus and analyze it to determine which canal is affected, which side is affected, and what is the type or subtype of BPPV is present, especially for the horizontal canal. Is it geotropic type or apogeotropic type? So if we get a positive case of BPPV posterior canal with the typical nystagmus, with a latency of few seconds, with a transient beating torsional nystagmus lasting less than 1 minute, with the associated feeling of a spinning, usually that's enough to diagnose comfortably benign paroxysmal positional vertigo of the posterior canal. So we can immediately proceed for the treatment. The most well-known maneuver to treat the posterior canal BPPV is called the Epley maneuver, published by Dr. John Epley from the United States. So this is a 4-5 steps maneuver intended to use the gravity to just move the otoconia from the posterior semicircular canal and to bring it back into the uterine. So usually the first step of Epley maneuver, it is the dixal bike test or position. So as you see here, this is Epley maneuver for the right ear. And when we start by bringing the patient into the dixal bike position, the otoconia moves and until it came here to the middle of the canal. So in this position, because the Epley maneuver depends on the gravity to work. We wait 1 or 2 minutes until all the otoconia came to this point. Then after 1 or 2 minutes, we turn the head briskly 90 degrees towards the healthy side. All the maneuvers, which are like manual or some physical therapy for the BPV, is based on moving the head gradually from the affected side toward the healthy side. So in every maneuver, after the first step, we move the head briskly 90 degrees towards the healthy side. We wait for 1 or 1.5 minutes until no symptoms, no nystagmus. And we can watch for the direction of the nystagmus on the monitor. If it's self-beating like the initial one, that means the otoconia is moving in the right direction. If it's reversed its direction, that means it's returning back. Then after 1.5 minutes, we go for the third step of Epley maneuver by turning the head 90 degrees towards the healthy side. In this position, the downmost ear become now the uppermost ear. And this is a critical position, very important. We keep the head for 2 minutes in this position. So at this position, the otoconia becomes near to the common cross here, about just to go to move back towards the utricle. So after 2 minutes, we just bring the patient in the sitting position. And in this position, usually the otoconia comes back, returning back to the utricle. Sometimes the patient in this position feels severe unsteadiness, feels like he's falling down. So it's important that the clinician keeps on holding the head of the patient. Usually it's just lasts for less than a minute or something. Then all the symptoms clear. There is another famous maneuver to treat the posterior canal. It's called the Simont maneuver, published by a French physical therapist. His name is Simon. And it uses the inertia to clear the otoconia from the posterior canal. So usually, like this is a diagram to show the Simont maneuver for the right posterior canal BPV. So in this maneuver, we turn the head towards the shoulder of the healthy side. So as you see here, it's turning the head towards the left shoulder. Then we bring the patient on the side lying position. So in this position, usually it provokes nystagmus and symptoms. We wait for 2 minutes in this position. Then that's very important for a Simont maneuver to, in the second step, to move the head very briskly in 1 second, more than 180 degrees, and bring the head into the opposite side of the table. But the movement should be very fast to work because it uses the inertia. So with this very brisky, fast movement, the otoconia, it can be cleared from the posterior canal. So the Epley maneuver uses the gravity, but the Simont maneuver uses mainly the inertia. But both of them, they do work. But like in the United States, Epley maneuver is more well known. But in Europe, Simon's also more known and commonly used. And both of them, they do work. But in our practice, we usually start with Epley maneuver. For horizontal canal or lateral canal, it is the same name, horizontal or lateral canal. We can use a special test to confirm its diagnosis. So it's called supine roll or McClure-Bagnini test. And it includes 4 steps. Usually you start by placing the head in the supine, Then after 30 seconds, we turn the head 90 degrees to the right and watch for any nystagmus. We wait until the nystagmus subsides. Then we bring the head back into the supine center position. We wait for 30 seconds. Then we turn the head to the left side. We watch for nystagmus and we wait until it subsides. Then we bring back into the center. And as I mentioned before, it depends on the location of the otoconia in the horizontal canal. It can give different types of nystagmus. Mainly it's called geotropic and apogeotropic type. So it depends on the location of the otoconia in the anterior or posterior arm of the horizontal canal. But as we mentioned before, it causes symptoms and nystagmus. Either we turn the head to the right or we turn the head to the left. There is many maneuvers published to treat the horizontal canal, but here we only will show you a very simple and easy maneuver. It's called Giuffoni maneuver for the lateral canal. And as you see, it's a 4-step maneuver. And this is intended to be used for the geotropic cases. So if we have a right horizontal canal BPPV of the geotropic type, we do the Giuffoni maneuver for geotropic type. So if the right ear is affected, we, as you see, like the patient sit down, then we bring the head 90 degrees towards the healthy side. So if the right horizontal canal has a geotropic BPPV, we treat it by placing the head of the patient on the side-lying position, 90 degrees on the left side. Then after like 1 minute, we turn the head 45 degrees down. Wait for another minute, then we bring the head in the sitting position. Usually we combine this with what is called the forced prolonged positioning maneuver. So after doing the Giuffoni maneuver in the clinic, we advise the patient to go home and to lie on the healthy side for 1 or 2 nights. So either awake, either sleeping, just we need to stay on the lying on the healthy side for like 8-10 hours, as much the patient can tolerate. And in this way, we use the gravity to help us to clear any kind of otoconia in the horizontal canal. Post-treatment instructions. So there is some controversy about the value of the post-treatment instruction. The controlled studies show that it's not necessary. But some of the instructions, they don't harm, they could be of benefit. They help to improve the recurrence and to improve the outcome. So let's to go through them. So first, post the treatment after the Eble maneuver or Simont maneuver, avoid any large or fast head movements for the first 24 hours after reposition. Otoconia believed to need like 24 to 48 hours to settle in the utricle and get attached back to its original place. So during that period, it's good if the subject can just restrict the head movements, especially for the posterior canal, the upward and downward movements. For the posterior canal, we advise the patient to sleep on the back with a high pillow or towels under the head for the first 48 hours. In case of lateral canal BPPV, we advise the subject to sleep in the healthy side for the first 48 hours. So by these 2 recommendations, we want to use the effect of the gravity to help to clear any residual otoconia and to prevent reflux of the otoconia back to the semicircular canal. And one of the valuable advice is to avoid sleeping on the affected side for 7 to 10 days after the treatment. This diagram to show how the towels can be used just to raise the head. So it brings like the posterior canal in a higher position. So it helps to clear any residual debris in the posterior canal. Avoid activities such as visiting the dentist, hairdressers, or swimming. Take care when shaving or using eye drops or washing the hair in the first 48 hours. And that makes sense. Use a collar. When the collar here, we mean by it a cervical neck collar or a neck collar to limit the head movement. Actually, the use of neck collar sometimes causes neck muscle spasm, and it causes discomfort to the patients. So it is unnecessary, and in our practice, we don't advise the use of the neck collar unless it's a very a case with a high recurrence. So, but usually we don't use neck collars because they cause neck muscle spasm. Vitamin D supplements. So many of the general population, they do have vitamin D deficiency or insufficiency. So as we mentioned before, that is the otoconia is composed of calcium carbonate. So vitamin D is important for to help its resorption in the endolymph. So whenever there is a vitamin D insufficiency or deficiency, supplements are advised. Even there is normal levels of vitamin D, there is no harm to take a very low dose or a daily maintenance dose of 1,000 international units of vitamin D on daily basis for a few months. This could improve the recurrence, and there is enough evidence that vitamin D supplements can decrease the recurrence of PPV. Other maneuvers, are other maneuvers to test the horizontal canal, like the bow and lean maneuver, like the head extension maneuver. There is other maneuvers to treat the posterior canal, like Gans maneuver. And there are special maneuvers to treat the horizontal canal and the anterior canal. So for horizontal canal, there is barbecue maneuver, Lambert Logrol maneuver. And we mentioned the forced prolonged maneuver and the Giuffoni maneuver. For the anterior canal, there is what's called the Iacovino maneuver or deep hit hanging maneuver. But we'll not talk about them because anterior canal is rare. Differential diagnosis. Some other conditions could mimic PPV, so careful examination, monitoring, and appropriate investigations can differentiate PPV from other conditions. The best care for PPV is that the subject should be evaluated by a well-trained clinician who is able to provide accurate diagnosis, repositioning, guidance, and proper and appropriate referral or investigations when needed. COVID time surfaces. So we can use the 5 questions screening from the Dizziness handicap inventory to screen for the conditions. And a more detailed history can be obtained through the questionnaire or a telephone interview with the healthcare provider. We ask the patient to try to determine which side provokes more symptoms, because this could make it easy to know which side is more affected. We can teach the patient to use their mobile phones to record their eye movements after placing the head in the provoking position. And they should record the eye movements until the symptoms disappear. A family member can help them during the recording. Then they can send the recording to the healthcare provider to review them. There is a tip or a hint here to optimize the recording, self-recording of eye movements by the patient. So go to your smartphone settings, change the camera frame from 30, which is the default in the most of the smartphones, and make it 60 frames per second. That gives a better quality recording of the eye movements and nystagmus, which make it clear for your healthcare provider to interpret them. We can use, if we are comfortable to diagnose posterior canal BPPV, we can teach the patient to do the home Ibli maneuver. It is almost similar to the office Ibli maneuver done by the clinician with some little modification. So the main modification is for the safety of the patient. We use a pillow. We don't hang the head down from the bed. This is called, in absence of the healthcare provider, this is could be difficult for the patient and inappropriate. So we teach the patient to put a pillow and to do all the steps of the Ibli maneuver on the bed completely. So as you see here, he starts by sitting in the bed with the pillow under the shoulders. Then suppose that he has a right BPPV posterior canal, he will be turning the head 45 degrees to the right, then extension of the head, but completely on the bed, using the pillow under his shoulders. Wait in this position for 1 minute or until the symptoms subside. Then briskly turn the head 90 degrees towards the left side. Wait for 1 minute or until the symptoms subside. Then make another turn for 90 degrees, bringing the undermost ear to be the uppermost ear. Stay in this position for 1 or 2 minutes, then you sit down. So this is how home Ibli maneuver can be done safely. And it can be repeated more than 1 time to be more effective. So this is something which can be used during the COVID time. Thank you.
All right, Ryan, I'm gonna let you take it away.
Wonderful. Thank you, Alfarghal. That was wonderful.
Thank you.
Just have a few questions here. We'll run by you.
Sure.
So, for you, Alfarghal, the first one comes from Jerry, and I think it's kind of right off the last slide you had there. Quick Google search, and I find a ton of at-home maneuvers. What are the dangers of doing these home maneuvers alone without a physician?
Honestly, we don't recommend the home exercises until in a very special situations. The ideal way to diagnose and to treat BPPV is that the patient goes to a well-trained and specialized clinician in dizziness, receive a very good examination, a very accurate diagnosis, and very effective and evidence-based therapeutic maneuver. I just put those slides because we did the recording at the time where is COVID prevent the regular services in different parts of the world. But this is very exceptional, and this is not the recommendation. So most of our patients we diagnose and treat in our office, and this is the best practice. In very exceptional cases, either with resistance, either the patient cannot come for a reason or two, we can do carefully and under monitor and supervision of a trained dizziness specialist. It can be done, but this is very, very exceptional situation. The mainstream, everybody should get examination with a trained professional, get a therapeutic maneuver with a trained professional in the office. So this is the recommendation.
Rare cases, okay. Sumit, this question comes from Mara Miro in the YouTube comments. With bilateral BPPV, which side do you usually treat first? Is there any rhyme or reason to how you treat which side first? What's the idea there?
Yes, this is actually I wrote a book chapter on multiple canal BPV. The book is named Understanding BPV, and it's in Amazon. So it just simply, if the symptoms from both sides, they are not the same. One side provokes more symptoms. So basically, we can start by treating the more symptomatic side. In our experience, sometimes, as I mentioned before, the side where is the patient lie on, like right or left, that's usually get more affected. Bilateral BPV is generally rare. It can happen in post-traumatic cases. It happened, but it's not very common. And it's either you have equal symptoms from both sides, or you have one side more symptomatic than the other, provokes more vertigo and more dizziness. So if you have a side which provokes more dizziness or vertigo, you can start by doing the Ibli maneuver from the side. Another point that is, you can, if you are using the Simont maneuver, you can treat both sides at the same session. But if you use the Ibli maneuver, if you treat the right side, you disturb the left one. So it doesn't make sense. If you have an equal symptomatizing PPV from the posterior canal from both sides, it doesn't make sense to do Ibli for both sides at the same session. So usually you do the most symptomatizing one, the one which provokes more vertigo, and after a few days just to do the other one. But if you want to go for simultaneous clearance or repositioning, a Simont maneuver, it allows you can simultaneously treat both sides. But let me to add a very important point that sometimes it's a pseudo bilateral. And what it means pseudo bilateral? It means that is only you have in one side, and it provokes more dizziness. But when you turn to the other side, it causes some movement in the inhibitory direction. So most of the cases, what happened, this pseudo bilateral BPV represent 50% of the bilateral symptomatizing cases. So if the clinician diagnose accurately the affected side, treat it perfectly, in 50% of the times, symptoms from both sides, they get cleared.
Gotcha.
So this is the three possibilities and how to manage. Thank you.
Gotcha. Thank you. Thanks for that, Alfarghal. I'm going to jump over to Sumit so we can get him involved on this question. This from Nima, who says, as far as residual dizziness after successful repositioning, how do you manage some of the residual symptoms?
Okay,
Perfect.
so
Alfarghal, we're going to let Sumit answer this one to get him involved.
Okay.
Thank you, though.
okay, so you have done a correct diagnosis. You have managed to locate the BPPV. You have done the right maneuver, and yet the patient is still dizzy. So there are a number of possibilities. So first, I'm going to just briefly say that suppose you have done the right maneuver and you have managed to move the particles. So that means that you have effectively treated the BPPV, yet the patient is still subjectively dizzy. The reason for this is if BPPV is long-standing, there is a central vestibular processing problem which goes on because the brain tries to understand the BPPV and recalibrates itself. So even when you cure the condition, this residual dizziness will remain. And we find this in pretty much everything with neuroetology, really, that sometimes the way the brain acts, it actually outlives the original condition. So in many of my patients, actually, I would say about 20 to 30% patients, this extra 30% patients who would be dizzy, even though I'm sure that I've done the right thing. And how do I know that? I'll see the disappearance of nystagmus. Now, that is absolutely crucial. There was one question in the forum which asked that, can there be a BPPV without a nystagmus? The answer is there is one variety of BPPV, which is extremely rare, less than 0.5%. That's when the particles collect in one particular area of the posterior semicircular canal. It has got two arms, a big short arm and a long arm. So it's one area which can generate subjective dizziness and nausea without any nystagmus, but that's very rare, so we won't talk about it. So what essentially is happening, therefore, is this residual dizziness is because of the brain function. And I would send these patients for a customized BPPV tailored rehabilitation, and we have developed a program here. So those patients are then subjected to this specialized we call it post-BPPV customized rehabilitation. This is essentially to entangle the mess that the brain has undergone, trying to give the brain the right idea that, look, buddy, your particles are gone. So you need to really keep your shape up, or you really need to get back in shape. The second possibility is, suppose with my maneuver, I have managed to dislodge the particles, not back to the utricle or where they have come from, but I've managed to displace them back to a different semicircular canal. Now that's called a canal conversion, which is also rare, but it can happen if the particles are very, very brittle. You know what I mean? They don't have enough weight. So in that case, the patient says that, no, I'm still very, very dizzy. So you'll have to repeat your Dix-Hall-Pike or the supine roll test or the deep head hanging, the different positions, and you then figure out whether you have actually done a canal conversion. And if you find a canal conversion, then you need to repeat your particle positioning again. So that's the second thing when the dizziness can persist after your maneuver. And the third thing when a dizziness can persist after your maneuver is even more rare, and that's called a canalith jam. Now, what happens there? This happens that you have moved the particles. Well, yeah, the particles are listening to what you are doing. You are moving the head. The particles are moving beautifully. But due to some anatomical variation in your semicircular canals, look, your canal is not the same as mine. Your canal might be broader than mine. There is a range. So what if your canal is very narrow and the particles refuse to move beyond a certain constriction or a certain kind of a narrowing? Then the otoliths of the particles jam. And this is called a canalith jam. This is much more common with horizontal semicircular canal rather than with the classical, more commoner variety, which is the posterior semicircular canal. So in that case, canalith jam is a difficult thing to treat because you'll have to increase the velocity of your particle positioning. And sometimes that's very difficult, especially in elderly patients with very difficult neck mobilities. So you can use a device. For example, a mastoid vibrator has been used to dislodge the particles. You put a vibrator behind the head. I haven't had many canalith jams in my life, maybe one or two. And usually what I did, I was lucky enough to increase the velocity of the head movement. So like something like a very drastic, high speed, high acceleration movement like a Simont. I mean, Apley is a much slower movement than Simont. I would use a Simont mainly for when the particles are stuck. I wouldn't use a Simont when the particles are free floating. But for a canal jam, I might have to use something like a Simont. So essentially, these three reasons, you might get a persistent dizziness after you have done particle positioning. And of course, it can come back, it can recur, and it can recur in a different canal. So there are a huge number of possibilities, which I don't think I'll be able to discuss them all. But I think I've given you the gist that these are the main three reasons and the three different sorts of treatment that you need to do.
And as a follow-up from that, Paula was wondering, is this different than 3PD?
Absolutely, it's very different. It's very different, Ryan, from 3PD. Now, the funny thing is, if one does not treat this chronic subjective dizziness after BPPV because the brain is trying a very long time to recalibrate, then there is a possibility it might lead to a 3PD. But BPPV, a properly treated BPPV, and the cure rate is more than 95%, then a 3PD should not happen. And if you can treat the post-BPPV dizziness as well, then a 3PD should not happen. This is a very good question from the person who has asked this, that what about the residual dizziness? Even if your positioning is right, what do? It needs to be treated. You just can't leave it alone. You just can't say, this dizziness, I'm not getting any nystagmus, everything is fine, hunky-dory, so just go home, this dizziness will pass. It's not enough to say that. You do need to treat that residual dizziness. Absolutely.
Gotcha. I think we have time for one final question. We'll ask you, Amy. Kim was wondering, when you have BPPV, are you more at risk for developing other vestibular conditions? Is there any correlation between them?
So in the recent years, we do know that BPV can lead to secondary conditions, especially if it's untreated. BPV is one of those ones that actually, if you get in the hands of the right specialist, it can be treated quite quickly. So if it can be resolved, that's really important. But if it is left for a long time, just as Dr. Sumit has said, then you will end up with with residual or secondary conditions. It can lead to migraine, 3PD. Even though we resolved the BPV, which was the initial insult, that damage can lead to further issues.
Gotcha. Wonderful. Well, I think we're right about time to lead into the next one, right, Q?
Yes, and we will be talking about post-concussion dizziness with Professor Sumit. For those that don't know, we'd love to just give a quick intro to Professor Sumit while he's live on screen with us.
Okay, so I'm going to introduce, it's an absolute pleasure to introduce Professor Sumit Dasgupta. He is the consultant audiovestibular physician at Alder Hey Hospital in Liverpool. He also is the head physician at Sheffield Dizziness and Balance Clinic. He has written many papers in both adult and pediatric diagnostic and rehabilitation, and he's my go-to if I'm stuck or I don't know what I'm doing, or there's a patient that's really, really complex. It's Sumit that I'm getting on the phone. So, you know, thank you for all your support over the years, and thank you for this presentation you're going to give us.
It's a pleasure to be here, and especially now that Liverpool has won the Premier League.
I love that perspective.
European.
Professor Sumit, we are about to begin your presentation, and we will see you afterwards.
Hello, good evening, and good morning to some guys, because I'm talking from UK, so this is GMT. And thank you very much to the organizers, Brooke and Chelsea, for inviting me to do this presentation about dizziness and concussion. Now, there are lots of, in a way, misinformation as to what concussion can do. So this lecture is essentially geared to one of the commonest, in fact, the commonest complication for concussion, which is dizziness. A little bit introduction about myself. I work in the UK in the beautiful city of Liverpool. We are known for our football club. I'm a consultant neurologist. I also have got an adult private practice in Sheffield, so I'm all over the place. So I'm a true Brit, still under lockdown, trying my best to get out, but still can't. I also hold a chair in the University of Siena, and I also teach in 2 other universities. So first of all, let me define what a concussion means. Now, concussion is a term which is used very generally in the sense, concussion classically is a definition which is an injury to the head that may or may not lead to a traumatic brain injury. Now that is concussion. So it is inherently suggested that concussion in that case is a temporary thing. And indeed, the classical definition of concussion is actually when all your symptoms following a blow to the head go away within 6 months to a year. But concussion is also used, in fact, in medical legally as well, when it leads to a more permanent sequel. So the real complication of a concussion is not just a temporary upheaval of brain function, but this has got a serious implication. It can lead to a permanent brain damage. So what exactly is a concussion? What is the mechanism of concussion? Obviously, purely by intuition, you can think of the brain as a soft tissue organ, which is protected very heavily by possibly the hardest bone in the human body, the skull bones. It needs to be protected. Obviously, it's your brain after all. Now, obviously, intuitively, if there is a blow to the head, then the brain will move inside that skull. And that is a direct injury. That is a direct blow to the head. But there is another mechanism which is equally important, and which sometimes gets missed. I mean, I appear for the court for so many times as an expert advisor, and I have seen that sometimes even experts miss this, that they do not consider an injury to the head without a direct blow. So what happens? Suppose you are in a car and the car stops. You are going at 50 miles an hour and the car you suddenly have to stop the car because of something, some obstruction. What can happen? You can either be thrown forwards, but you'll be prevented by the airbag. So your head will be protected against smashing into the windscreen. But what can happen is the moment you stop, your brain continues to move within the skull. And the skull is a rigid structure, it doesn't expand. So the brain gets squeezed and compressed. And in the process, it sustains an injury. This injury is called the classical acceleration deceleration injury, as I have put that in a figure, which is wonderfully drawn by the Mayo Clinic. So when the brain moves, the brain matter moves inside the rigid or bony skull, it is liable to be injured. And that's a classical acceleration deceleration injury. So the importance of this is essentially you do not need a direct blow to the head. You can have a concussion or a head injury, or even leading to a brain injury by the acceleration deceleration process. And the third type of injury is, of course, a blast injury, where you can be thrown into the ground, where you sustain a direct blow to the head, or if you manage not to fall into the ground, then the shear blast, the air pressure wave of the blast, can cause exactly a similar thing as an acceleration and deceleration. And the blast injury, I've seen many soldiers. I used to work for the British Army. I've seen many soldiers who actually sustained a blast injury without any direct injury to the head, and they ended up having a traumatic brain injury. So these are the three mechanisms by which a head injury can lead to a brain injury. Now, at this point, let me quickly tell you the difference between head injury and brain injury. You see, when you are walking inside your house and you have a small bump to your head against the door, that is a head injury, believe me or not. And some of the neurons in your brain are lost, but they are not that severe that they will cause any functional or clinical effect. Now, that's a head injury. Has that head injury led to any tangible brain injury? No. Therefore, head injury and brain injury, the two terms are used interchangeably, but there is a difference, and this becomes important in a court of law. You can have a head injury without a brain injury, but a brain injury is almost always following a head injury. Now, brain injury, I'm talking about a traumatic brain injury. You can have a metabolic brain injury, you can have different pathologies causing a brain injury, but that's different. A traumatic brain injury almost always follows a head injury, but a head injury does not necessarily lead to a brain injury. And these two terms must be very, very important to distinguish and make a distinction between the two of them. Now, obviously, the head consists of the ear. I ask my students, why is the inner ear or the ear located in the head? Why can't it be located in your thigh? What is the evolution? Why does the hearing mechanism and the vestibular organ need to be located in the head? And the simple reason is its neural connection. Can you imagine your ear located in the thigh? It has to make such a long journey to go to your brain. So nature has solved this problem by locating the ear, which is a nervous or neurological structure, very, very close to the head. So the tracts and the pathways have got the least to travel to make their connections. And the inner ear consists of a very important organ called the vestibular system, and that is in the head. So the vestibular system can be affected or can be injured following a concussion. So obviously you can imagine that a blow to the head or an acceleration, deceleration, or a blast injury can actually injure the vestibular system as well. And today, because I'm a vestibular specialist, I'll be emphasizing mainly on this vestibular injury, which is sadly very much underdiagnosed, very much misdiagnosed, often missed, and often not picked up even by experts. And I've seen this to be happening too many times, and I'm sure everybody will agree that this is like a kind of a disease or kind of a pathology which is hidden. But this is very real. And the commonest symptom which can follow damage or an injury to the vestibular system is a dizziness. And therefore, a vestibular injury can be accompanied with dizziness in most of the cases. However, there are instances where your vestibular system might be spared and your brain is injured only. In that case, what happens is you can still get a dizziness. Why? Because remember, the vestibular system sends all its connections to the brain. So the final processing of the vestibular input or the dizziness is actually in the brain. And if the brain can't do it because of the injury, then the net result is a dizziness. So at the end of the day, dizziness is a symptom which is produced by an injury to the vestibular system or the vestibular connections in the brain. So what is the vestibular system? I'm showing you here two figures. One is actually a video and the other one is a figure. Now, the vestibular system, as I said, is located inside the inner ear. That consists of really 5 different organs. You see these semicircles, these are the canals we call semicircular canals. So one looks at the top, one looks at the back, one looks at the side. They sense when you're moving your head in different directions, in different axes. These are called the angular motion sensors. In the middle, you have got the utricle on the top and the saccule at the bottom. These two are gravitational sensors. Now, these are ubiquitous across the animal kingdom. Even the smallest plankton will have some kind of a gravitational sense because gravity always pulls you down. So 3 semicircular canals and 2 gravitational sensors. Now, I once had an argument with a hepatobiliary specialist who said the liver is the most important organ in the body. That's a gross 20 kilo organ. Compare it to this bit. This is less than 1 millimeter, with 1 cubic millimeter in diameter. In every micrometer, 64,000 sensory hair cells are packed. Now, this is nature at its finest. If this is not fine, then nothing is. In fact, I tell my students that this comes out of science fiction, really. So these 5 organs, they generate or they kind of contribute to 60%, as much as 60% of your normal balance. What is balance? Your orientation in space. You have to orient yourself in space at all times so that you know where you are at any given point of time. Otherwise, your life is not compatible. And vestibular system contributes to 60% of your normal balance. It sends its connections to the brain, as I said, and then the brain sets up a number of what we call reflexes to your eyes, to your spine, to your legs, to your arms, to your neck, so that you can actually be stable and you can maintain your balance and be stable in your posture. Now, this is the vestibular system, and as you can also see, this bit is the cochlea or the hearing system. So the cochlea and the vestibular system both are contained in that part of the inner ear we call the labyrinth. And when we talk about concussion, we sometimes say a labyrinthine concussion. Now, this is a small video, which hopefully will take you through the whole thing. So as you can see, that's the outer ear, which you can see, and this is the vestibular system. These are the 3 semicircular canals. When you are moving, the semicircular canals with the fluid inside them are moving in different direction, send the signal to the brain, and the brain tells you what's happening. And then this is once again a fly through. That's the whole labyrinth, the cochlea and the vestibular system, the 3 semicircular canals in different directions. That's the nerve which makes the connection to the brain, different directions of movement, which the vestibular system picks up and sends to the brain. Now, very importantly, these are the different hair cells, which I said 1 micrometer consists of nearly 64,000 of these cells which move as your head moves. And these are the fine, what we call hair cells or the neural cells, which move in different directions, driven by the fluid. This fluid is in the inner ear, and the fluid moves when the head moves and moves this bit of the semicircular canal. And that's how a signal is set up essentially. Now, this is in the canal. This is when you are actually moving, and this is happening continuously. That's the gravitational sensor. You treat these chalk particles. These chalk particles are very important. They're called otoliths, which essentially sense gravity. And please remember this, because there is a condition where these otolith particles can actually slip after a blow to the head or otherwise into the semicircular canal, generating a very distressing condition, which we will talk about very briefly later. So this is essentially the vestibular system, highly complex, and as I said, coming right out of science fiction. And unfortunately, awareness is not as wide in the whole medical and paramedical fraternity as, as let's say, for example, the heart or the brain or the liver. So That is an important thing. So what is vestibular concussion? Same mechanism of damage as head injury. And the quoted incidence is about 15 to 75% after a head injury, but the ones which really come to light would be less than 10%. And by definition, as I said, concussion resolves completely by 3 to 6 months because the brain compensates and recovers, but it can lead to a permanent damage. What are the symptoms? Dizziness, as I said, and obviously, if your balance is compromised, you might be unsteady on your feet. That is, you walk, and you get different kinds of accounts from patients saying that, my husband walks like a drunken man. So it's kind of lurching gait, unsteady, very broad base, so your feet are wide apart. The third one often gets dismissed as a visual or an eye problem, because remember, the eyes can be hurt in a head injury too. This is dizziness in challenging visual surroundings. If I go to a superstore, the bright lights, that really makes me very, very imbalanced or dizzy. I cannot see the world moving past when I'm in a car. This is called visual vertigo, and this is actually dizziness in challenging visual surroundings, which by default comes from a damaged vestibular system and not from the eyes. And this is a very, very important symptom which often does not get picked up by experts. The fourth one is also very important, difficult navigation skills. A common problem after a head injury is a complaint. I bump into things more frequently than I'm doing now. So what does that mean? I'm bumping into a door frame, right? When I'm going into the car, I'm bumping into the door of the car. Then I lost my way when I'm trying to come back home. Now, this is classically attributed to a brain injury, but it has been shown recently that one of the semicircular canals has got a very, very key role to play in case of a difficult navigation skill. The fifth one is also not very uncommon, vertigo, that is spinning on changing positions of the head. So you are trying to lie down, trying to get up, trying to take something from the top shelf in the kitchen, you get intensely dizzy. So any movement of the head against gravity makes you very, very dizzy. And this is because, as I showed you in the last slide in that video, the small particles can shift from the gravitational sensor, that is the utricle and saccule, into the semicircular canals, and they irritate the canals. And that's what happens. And it's very easy to be treatable and curable. The next one is also not uncommon. And once again, this is sometimes branded as a headache following head injury, but a head injury can generate a condition called vestibular migraine, which behaves exactly like a headachy migraine, but here the headache is replaced with dizziness. So exactly same symptoms as migraine, but you don't have a headache, you have a dizziness. The next one, difficulties to move in darkness. Now, obviously, when your vestibular system is affected or injured, you rely heavily on your eyes for balance. And you take away all the different cues for your vision. That means darkness. What happens? Your vestibular system decompensates and becomes very difficult for you to move in the dark or when the light is dim. And of course, your general imbalance leads you difficulties in moving in stairs, lifts, escalators, sometimes driving. In fact, driving is a key thing, especially driving at nighttime, which is sometimes very difficult for persons who have had a labyrinthine concussion or a damage. As I said before, this is often misdiagnosed, underdiagnosed, or not diagnosed at all, but so far you can appreciate that this has huge implications to lifestyle. In fact, when I see my court cases, when I see all these medical legal cases, when I ask them to fill up a psychometric questionnaire, their quality of life is significantly centered around this imbalance and dizziness. And the other bit which significantly bogs them down is the cognitive or kind of higher planning skills, organization, memory, etc. But these two are very, very important, and these two. And one of the things about a labyrinthine damage or a concussion is if it doesn't get treated, right, it might lead to a condition called 3PD, or persistent postural perceptual dizziness, which is a chronic condition. A person continuously feels dizzy throughout the whole day, and this is a very, very difficult condition to treat. So we should not let any vestibular weakness following a vestibular injury to this stage, because vestibular injury and its aftermath can be treated very, very well with a number of modalities, which would be a part of this webinar. how do we then diagnose a concussion and damage? Now, obviously, history is crucial. What are we looking from the patient? What do we want to tell us? Now, the important thing which we are looking for is to establish the mechanism of the injury. So the mechanism, as I said, there are three. And usually you will find the mechanism of the injury very beautifully described to you by either the patient. Now, sometimes remember, these patients, they are speech deprived because of the head injury. It can be a severe head injury. Sometimes they don't recollect, they don't have any memory. Sometimes it's their partner or whoever is accompanying them giving you a surrogate history. Sometimes it's the medical records. But at the end of the day, we will have to coax this story out as to what is the mechanism of the injury. And why is that important? This is important because remember, even a very trivial head injury, I'm not talking about a brain, even a trivial head injury can knock out the vestibular system completely. And that is a real thing. So it is very important that we take a good description of the injury, and that can take some time. Then, of course, we perform a series of clinical tests. And as of last count, I personally perform about 23 different clinical tests in my clinic to assess how much of the vestibular system is affected. I provoke different body movements, head movements. I challenge their balance by asking them to stand on one leg with their eyes closed. So I do varieties of tests in order to assess their balance. One very difficult test sometimes is asking your patient to balance on a soft surface. So you take away the hard friction from the ground. You take away, ask the patient to close his eyes, so you take away the vision. So your balance is now entirely driven by your vestibular system. And in that case, if you have got a damaged or a weak vestibular system, you'll fall. And obviously, you'll have to do this in a safe and secure way so that the patient doesn't sustain any injury. But at the end, all these tests and the history gives you a very, very good idea. And you can prove your case that there is a significant labyrinthine injury which has caused all these problems. After we do clinical tests, I would send my patients to the laboratory where all the different clinical tests which I have done can be physically measured by very high-tech software-driven equipment, which in fact have revolutionized the whole vestibular diagnostics. These tests are very important because these are physically quantifiable. In other words, these can tell you exactly what percentage of the vestibular system is affected. At the end, the idea is once again to get a comprehensive picture as possible. And finally, we'll have to exclude, because dizziness can also occur from just a brain injury sparing the vestibular system, in which case we will have to exclude a neurological cause for dizziness, which you can make out not with any difficulty from all the different tests you have done. For example, the way your eyes move would be different if it's a vestibular injury than if it's a brain injury. So as you can see, this is a very comprehensive test battery, which includes the history, which will lead you to a correct diagnosis. Now, why do we need a diagnosis? This is to formulate management and rehabilitation, which I'm sure features heavily in this seminar. A few examples of tests. Obviously, I'm not going to go into any technical details, but these are the two latest tests that we do. This is actually from a small girl, I think 6-year-old. So what happened was she was trying to reach for something at the top from the fireplace, and she used a stool, fell from the stool and hurt her head. No loss of consciousness, no vomiting, absolutely nothing. Went to A&E because she had a bump. Casualty discharged her home. She was perfectly okay. 3 months down the line, her teachers complained she's not paying attention in class. Standard hearing test. One side, that is the right side, the labyrinth has been knocked out, which means there was no hearing, and the vestibular function tests were all over the place. But look, the child was perfectly normal from the functional point of view, and that is because of central compensation. So this is one of our tests. This is the right side of the inner ear. This checks the semicircular canals in the high frequency. So these movements are checked by this test. And this high frequency movement, a simple analogy would be when you're trying to join a motorway, we call in UK, I think you guys call it a freeway. So when you're trying to join a freeway from a slip road, your instinct is that's the frequency, high frequency movement, which we check here. And as you can see on the left side, that's the blue is the head movement, the green is the eye movement. The eyes move in harmony with the head when you move your head like this, but out here, the eyes are not moving. There's a clear lag, and the brain tries to catch up with it with these spikes we call saccades. Now, this, as I said, has changed the way we look into vestibular diagnostics. I think if you have to do any one test in order to do vestibular diagnosis, it would be this test. Yeah, granted, it doesn't give you all the information, but the information it gives you is absolutely crucial. The second test which we have done here is same child, and this is the VEMP test, which is a very interesting test and which is now getting refined as we speak. Not very easy to do in kids though, but this test checks one of the gravitational sensors. So we stimulate that gravitational sensor with sound, and it should return a normal response. When it doesn't return a response, then obviously it's not functioning properly. As you can see on the left side, it's beautiful, this peak, this curve that you see, this blue one, this is a peak that you see which is normal. On the right, you see it's a flat line. So we took a good history from this child, and obviously she is 6. Can I tell you something, that if you're taking a history in a child with a head injury, the most difficult group of patients would be the teenagers, because even if they don't have a head injury, they hardly communicate. If they do have a head injury, they don't talk at all, right? So it's just grunts and hers and So it's very important that you take the person around the child on board. Now, of course, this might not happen in adults unless they're very significantly traumatized by the brain injury, which has kind of left them in a very significant disabled state. So these are the 2 latest tests. As I said, if someone has to do some vestibular diagnostics, these 2 tests are absolutely crucial in addition to others. So just the arrows that there is no response. We have to fully assess the hearing of the person who has had a concussion, because as I showed you, the cochlea is just next to the vestibular system. And if the vestibular system is affected, then just by their geography, the cochlea is likely to be affected too. I mean, about 2/3 of labyrinthine injuries would have both cochlea and vestibule involved, about 1/3 each where only one system is involved, either the vestibular system or the cochlear system. Now, treatment. Once we treat, why did we have to go to such lengths to diagnose? Vestibular rehabilitation, and that has to start early. If you are late, you are opening up the chances of a 3PD, a difficult condition to treat, and this will be covered extensively, so I'm not going to any details, but customized vestibular exercises, depending on what you have found, has got a brilliant and absolutely fantastic outcome. You might have to treat the migraine with medicines. The BPPV, or the particle moving from the gravitational sensor to the semicircular canal, it's called the benign positional paroxysmal vertigo, very common condition, and that you can treat with head movements we call particle repositioning, leading to a complete cure. Now, obviously, persons with labyrinthine concussion or damage, they do undergo a compensation by the brain itself. Any factor which can lead to a problem or an inability of the brain to do this compensation will prolong or sustain the vestibular symptoms. So obviously a brain injury does lead to kind of things like higher center problems like memory, planning, then psychological mood changes, depression, etc., etc. These also need to be treated aggressively if you want to achieve complete compensation. And often a situational awareness, that is counseling from the vestibular specialist, and self-awareness is very important. So it's not a one discipline thing, it's hugely multidisciplinary, and they have to coordinate, and we should be working in a team and kind of tackle this problem head on rather than keep it for the future. And for that, diagnosis is absolutely crucial. So at the end, last slide, your vestibular system is now being called your internal GPS after that navigation thing has been discovered. So it coordinates and teams up with different systems in your body, and it leads to yourself orientating yourself in this vast infinity called space. And to prove this point and to emphasize how important is it for the system, and therefore an injury can knock out many things, I'm playing you this video. Thank you very much.
All righty. Ryan, what are our questions? It looks like you're on mute.
Thanks, Q. Just one question here for you, Sumit, from Paula. Can you elaborate a bit on concussion becoming 3PD, and then how is that treated and managed?
Okay, so as I said, that concussion, if it leads to labyrinthine or a vestibular damage, the initial presentation will be the different vestibular symptoms, of course. If there is no treatment offered, and this time frame is variable, I mean, it can be 6 months for one person, it can be a year, it can be 2 years, 3 years, because remember, the brain is an exceedingly resilient organ. But in some instances where the brain is unable to compensate properly, you would progress to the stage of 3PD, where the brain will be in a perpetual state of what I usually call a misunderstanding. So the signal is being sent by the damaged vestibular system, but instead of concentrating on how to get rid of it, the brain is actually getting more involved in not understanding what's coming from the vestibular system. And that is the situation where you end up with the 3PD. Now, the Barani Society, that is the parent vestibular body in the world, they have come up with different criteria for diagnosis of 3PD. It's not a psychological condition. It is now considered as a physical condition, and the most common cause is an untreated vestibular condition. And obviously, a vestibular damage from a head injury will be a part of it. Now, if it happens, the typical symptoms are, of course, a chronic, what this was used to be called chronic subjective dizziness, so CSD, which has now been changed to 3PD, and a variety of situations where you will feel intensely disorientated. For example, your visual vertigo will persist for a long time. You might get this undulating kind of feeling as if you are in space, swaying right and left or back and to and fro. All these things, they happen. Once one progresses to the 3PD stage, as I said before, it's a very difficult thing to treat. And at the moment, I think the treatment is a little bit controversial because some of us have got very good results with vestibular rehabilitation. Some of us have got very good results with pharmacological, with medicines, actually. We'll have to work closely with the psychiatrists as well as the neurologists. Some of the patients, they have shown a spontaneous recovery once they know what's going on, so they devise their own coping strategies. So there is no really one recommended treatment. I guess that what I would do, I would take one thing at a time and go to the next stage if one thing is not working. But overall, the outcome is, it's still quite debatable. Sometimes you achieve spectacular results, sometimes you don't. And I'm sure both Brooke and Amy will agree on this.
Yeah, I mean, I think I definitely agree with that. And we, work in a very collaborative approach with these patients. So working closely with psychiatry, even EMDR treatments, following up with vestibular rehabilitation and a lot of optokinetic exposure and visual desensitization. So there's a lot, we always call them like tools that we're putting in the toolbox. So there's got to be quite a few different resources that patients are accessing, and the right hand has to know what the left hand is doing.
Yeah, and one more thing I'd like to add, because in this world of digital world, one of my colleagues in France, he is trying successfully some virtual reality, not just optokinetics, Brooke, but some virtual reality which he has devised, and he has shown me one of them where I almost fainted because I thought it was very severe. But I think maybe that is a future way ahead of treating 3PD with virtual reality.
Yeah, I think there's some really neat pieces to that.
Brooke, one question for you. This just came in. How does concussion treatment differ between, or post-concussion dizziness treatment differ between athletes and just normal civilians?
Yeah, I think that's a really good question, because athletes obviously have different normative data. And so when we're working with patients to base their thresholds or what we're going to expose them to or what's going to be kind of in their treatment program is going to be very different than a mother who's just attending, gym classes weekly. So it's really important to make sure that specifically you're working to those athletes' thresholds and really working with their trainers or working with, if they're a professional athlete, their actual team that's surrounding them to maintain not only, very slow and steady progress, but also make sure that they're reaching their maximum levels and previous performance levels.
Got it. Q, you want to take a brief that's all the questions we have from the dizziness or the concussion stuff. So Q, you want to give us a little intermission and then we'll come back?
Done. All right, we now have Amy Lennox Bally. You're going to be presenting the next presentation, which is on anxiety, stress, and dizziness. Dr. Pierce, would you mind giving a quick intro as to who Amy is? I mean, everyone in the chat already knows her, but for those that don't know.
I will tee her up, yes.
Yeah.
So Amy Lennox is going to be presenting. So she is an audiologist out of Liverpool, and she's amazing. So I think getting into the discussion, or after the discussion, you're going to see obviously all of the value that she's going to be able to provide. She owns her private clinic in Liverpool and does see patients in the clinic diagnostically and therapeutically. And then she trains all over the world clinicians to make sure that we're continuing to kind of spread best practices and help get a lot of this into mainstream clinics so it's accessible all around the world.
All righty. Well, Amy, I'm going to let you take it away on this presentation, and we will chat with you after.
Hello, everybody. It's an absolute honor to be talking to you today at the first Vertigo Day. Now, I've been given the task of talking about anxiety and dizziness, which is quite a tricky subject to talk about because it's such a personalized, individual thing. If you're a patient, I'm just hoping that you'll get some resources and tools and tips and tricks to look at after today's presentation. And if you're a professional, I'm hoping that these concepts are something that you'll look into reading up on afterwards. And again, I'm hoping you'll get some resources that you can give to your patients. Okay, so let's get going. So I'm going to open with talking about 3 of my patients. I've changed some details just so they can't be identified. But these are 3 quite common examples that we get through our clinic. First, we've got Samia. Now, Samia is a young mum. She's got her dizziness about 8 months ago, and she had a vestibular neuritis. She recovered in terms of the vestibular neuritis, recovered 8 months later, all her vestibular function tests were normal, yet she still felt kind of like this bobbing, moving sensation. She was off work for 3 weeks initially, but she had quite a hard time with her boss. He was not very understanding and pushed her into going back to work as soon as possible. Then we've got Margaret. Now, Margaret is retired. She's been dizzy for 15 years. She has a vestibulopathy, so she has a vestibular weakness on one side, but she has just not managed to get any better. She's had tons of rehab. She's been to lots of different people, and then she ended up through my door. And then lastly, we've got Vince. Now, Vince does have a vestibular migraine, which means that he will get episodes of dizziness now and then, but it was fairly well managed. But he'd noticed over the last 6 months that his episodes were increasing, and he just felt that it was starting to get out of control again. So these are 3 example patients, and what I will do is I'll go through the concepts and I will wrap it back up at the end with what we did with each 3 very different cases. They all had an emotional element to the dizziness. Okay, so with anxiety and dizziness, it's very much a chicken and egg issue. Dizziness is a symptom of anxiety. So when you're feeling anxious, you tend to hyperventilate, breathe shallow, and that in itself can induce dizziness. However, if you get a dizziness and you've never experienced anxiety in a severe way or a moderate way before, dizziness itself can induce a lot of anxiety. So with you, when you're looking at this, what came first with you? Do you have anxiety? Did you have dizziness and then anxiety came on? Or maybe you're not even aware that there is some emotional element to your dizziness. Now, you'll get an in-detail talk about vestibular compensation on Vertigo Day by the lovely Margie Sharpe. So she'll give you all the information as to what vestibular compensation is. This is what we are aiming for when we treat you for dizziness. And if you compensate, usually, most of the time, your quality of life gets pretty much back to the way it was. There are barriers to vestibular compensation, and we need to unpick what they are. And they all fall under this kind of anxiety spectrum. First one's lack of diagnosis, a heightened autonomic nervous system. As a result of that heightened autonomic nervous system, you adapt maladaptive techniques. Because of those maladaptive techniques, grey matter in your brain changes, and then you may or may not suffer from certain chemical imbalances. And let's go through them in detail. The fear of the unknown, that's a big issue with vestibular disorders. A disease known is half cured. It's a great saying from Thomas Fuller, who was a physician in the 1700s, and I think it fits very much with patients with vestibular disorders. I often get patients through the door who have had dizziness for many years and often not been given answers. 40–50% of the time, if they get a diagnosis, they can move on with their lives and pretty much have basic vestibular rehab, and they start to feel better. There is on average 4 to 5 years in the UK and the US, that's the latest statistics, before patients get a diagnosis for their dizziness. And that's something that we here at Hypatia Dizziness Specialist Clinics and the guys at Dizziness and Vertigo LA are trying to change. The autonomic nervous system, that is something that all of you will know from an animal point of view. So animals will, if they're under threat, they will either fight, fly, or freeze. But humans have this very primal wiring as well. Now, the autonomic nervous system is kind of driven from your vagal nerve, and your vagal nerve runs all the way through your body, and it connects to every major organ
It connects your heart, your lungs, your digestive system, your liver, your pancreas, the lot. It's your gut brain, so it's your second brain. And you know when they say you've got a gut feeling, it's coming from your vagal nerve. It maintains things like blood pressure, how much oxygen is in your blood, and if you are in a heightened autonomic nervous system state, you will be in fight or flight or freeze mode. Now, it's very normal for you on a daily basis to kind of have certain stresses throughout the day, become stressed, your autonomic nervous system heightens, but then it should be able to regulate itself and come back down to a normal state. What happens with people who are dizzy for a prolonged period of time, their autonomic nervous system remains heightened and they cannot get any recovery from it. That in itself is an issue and it affects your overall well-being. The longer you remained in that heightened state, possibly the more unwell you will feel over time. Because you're remaining in a heightened autonomic nervous state, you probably will adopt some maladaptive techniques. Now, this concept is quite tricky to talk about because maladaptive techniques are different, they're very individualistic. So, for example, Samia, my first patient, she had normal vestibular function. I would give her very different advice to what I would give Margaret, who did have a vestibulopathy on one side. One common maladaptive technique that you will all be doing is not moving your head enough. Patients tend to come through the office and they have very stiff necks and they will not move their head. That actually stops you from recovering from your vestibular problem. Other maladaptive techniques are any kind of lack of movement, restriction from daily activities, any avoidance behavior. So if you avoid going places because of how it makes you feel. Introspective monitoring, that just means when you're kind of really guarded and really kind of look and think and feel about how your body is. And then guarded postural control. So an example of that is somebody who is very careful when they walk in an unnecessary way. So when you are initially dizzy and you have a dizzy attack, yes, it's okay for you to kind of withdraw, ground yourself, get yourself feeling a little bit better. But once you're coming out of that, you need to start trying to push yourself. It takes a lot of self-motivation and some good humor and some good guidance to kind of get through that maladaptive stage. Maladaptive techniques, though, are known to make changes in grey matter in the brain. Now, grey matter is responsible for concentration, memory, attention span, and coordination. And it is well listed in the literature that there are changes in patients' concentration, memory, attention span post a vestibular disorder. And there can be many levels to that. But it's important to be aware of that because there are things that you can do to help with this. And it's a case of you don't use it, you lose it. So I'm going to give you a list of tips to do coming up. There's things like puzzles, brain training apps, and there's a lot of technology out there to help you. The final point I want to talk about is our neurotransmitters. So these are your chemicals. Now, your serotonin, your dopamine, they're your happy chemicals, and they're what make you feel joyful. They help you sleep well. They are produced when you exercise, light exposure. So these are very simple kind of things that you can do to kind of improve those. But what's most interesting is GABA. Now, GABA is your common neurotransmitter. GABA is what's released during the vestibular compensation process. However, if you're feeling a lot of anxiety, the GABA is released to maintain your heart rate and calm other parts of the nervous system. If you have anxiety, your the capacity of your GABA is going to be lower because it's going to be used somewhere else, and then you're going to have less capacity for vestibular compensation. So what does this all mean? The crux of the matter is that if there is some anxiety, whether you know it's there or not, it's up to the clinician to try and unpick what is going on there. Vestibular rehabilitation on its own, giving you simple exercises, will not work on its own if there is an emotional element to your dizziness. And you will need some sort of personalized program. Now, there's not many specialists out there that will be able to give you anything. I don't think there's any, but knowing that there's resources available and kind of steering you in the right direction for what you need is key to this. So here's an example of some of the programs that you may or may not need. So talking therapy. So if there's a history of trauma or anything like that, a talking therapy would be very good for you. I have had patients in the past who are not comfortable with talking about whatever has happened to them. So there are non-talking therapies, and the literature does say that they can be just as, if not more, effective. Polyvagal stimulation, again, very well researched in general anxiety, and now there's been some publications around vestibular rehab and polyvagal stimulation. Visual desensitization, resilience building, confidence building, that's something that we can now more easily provide in a vestibular rehab clinic due to the technology advances. CBT, which is cognitive behavioral therapy, and there's many online applications available for you now. Mindfulness and meditation, I recommend this for everyone. I recommend this to my friends, my family, anyone, not just if you have vestibular issues. Deep relaxation, diet, exercise, lifestyle changes, occupational therapy. If there's any issues around work that are making life harder for you, it could even just be the screens that you use, and if you have to use 2 screens, this is something that occupational therapy could help you to make that easier for you. And then sleep hygiene. We're surrounded by tech all the time, so sleep hygiene kind of means like, how do you wind down before you go to bed, and can you avoid being around social media and tech late at night? Is the things that you can do to soothe your body before you go to bed. So with the current situation with social distancing, what I've done for you is put some quick wins together for you to have a look through, because it's a lot more difficult to access the services. There will be a link below for you to click onto, and you'll find a full resource pack to access links, apps, resources that might help you with what's listed on this page. Diet, hydration, and exercise. Every doctor will tell you, every specialist will tell you, no matter what your condition is, that they are the key points. You want a good foundation, so you want strong muscle tone, good hydration, good diet. Vitamin levels and a blood pressure check are usually quite easy to access, even now. I think the pharmacies are starting to offer those services. Vitamin D and B deficiencies are known to cause dizziness problems. So if you just get all that checked to make sure that you have a solid foundation for us to work on. And again, as much sleep as you can possibly get in a night is good. Identify any maladaptive techniques and try and reduce those safely. So if you feel that you are withdrawing, not going out for a daily walk, you should be going out as much, well, at least once a day to get some exercise. You need to do some self reflection to see what issues or what things that you might not be doing because of your dizziness. Try and learn to identify any emotional triggers. This is difficult because often we don't know what triggers us, and there's a full booklet in the resource pack that I've put together of how to identify those emotional triggers and then how to deal with them or how to shift
from that triggering you. Human life is stressful. It does go up and down, and it is okay to be triggered, but it's like, how do you ground yourself and how do you bring yourself back to center? Breath work, there's loads of great apps out there to help you learn to breathe deep. If you're an anxious type of person, you probably only use 5%, 10% of your lung capacity. Breath work is a really great way to change those oxygen levels in your blood system. Mindfulness, there's loads and loads out there on mindfulness, and it is just a great way to calm the autonomic nervous system. Brain training apps are really, really good for grey matter, and they're actually more entertaining than some of the other things you can do. But if you have any hobbies that you like, so gardening, cooking, painting, colouring in, anything that encourages fine motor skills, so anything which is small that you do with your hands, that's really good for grey matter. Online CBT, there's a few free services that provide that. Interaction with other people, yes, that is difficult at the moment, but don't be withdrawing yourself and don't be isolating yourself without any kind of Zoom calls or people coming to your garden. Try and have interaction with other people, but the key to this is that they are safe people that that comfort you. You don't want you need to have that in your life, not just people that make you feel stressed. Movement energy, so what that means is kind of state shifting. It's like what Taylor Swift says, shake it off. So what you should do is, if you're in a stressful state, if something's irritated you, what can you do to shake that off? Can you just stand up, go for a walk? Can you do a little dance? It does change the way you're thinking. Listening to music, this is part of kind of polyvagal stimulation therapy. It has to be upbeat, so no sad ballads. Pop or folk is kind of what is recommended to kind of stimulate the vagal nerve. So let's bring it all back together and let's talk about Samia, Margaret and Vince again. So if you remember, Samia was the patient who was dizzy, had a dizzy spell 8 months ago. She had normal vestibular function, but she was still feeling quite wobbly and not quite right. She had some polyvagal therapy, some CBT, and more vestibular rehab. And she pretty much made a full recovery within about 3 weeks. Then we had Margaret, who'd been dizzy for 15 years. She needed a little bit more help. So we did some polyvagal stimulation, some CBT. She went to counselling, and she also had some virtual reality rehab. And after about 6 months, her scores, she improved a lot. She was a lot better, and her quality of life lifted. We also encouraged her to spend more time with her friends, because she'd withdrawn completely from them. Now, Vince was an interesting one, very busy guy, and he came in and he didn't acknowledge that he had any form of anxiety at all. But after spending some time with him and unpicking what the issues was, he'd been doing a lot more travel in the last 3 months, which was the period in which his attacks had increased. And we were trying to figure out what were the triggers. And for him, the trigger was packing his car. It sounds silly, but he found that packing his car up in the morning would trigger him and make him feel unwell for the rest of the day, so for the following 8 hours. So we just worked around that and got the lifestyle around that change. So his wife would help, the kids would help, or he learned to pack the night before. And he felt just by making that simple switch, that was all he needed. So yes, he will still get episodic vestibular migraine, but he wasn't getting triggered every time he had to travel for work. So thank you very much for listening. You can find all the resources in the link below. And there's the website to my training, which we provide training for vestibular specialists. and the clinic itself, which is in Liverpool, United Kingdom. Thank you very much.
Thank you, Amy. One quick question that I had that came up is, it's like you have to, as far as the chicken and egg problem goes, unpack both of these simultaneously, the anxiety as well as the actual vestibular dysfunction. I guess, how would you recommend a patient going about doing that? Do they need to have these two different specialists coordinate together? Is it about finding a specialist that can do it all? How do you usually recommend a patient do that?
Well, I would hope that the kind of the understanding around this has changed over the last 5-10 years. And I know that most diagnostic services are offering some sort of anxiety screen to see if there is an anxious element to their dizziness. It's very difficult and to have two specialists involved, but it doesn't matter what the dizziness disorder, there usually needs to be a multidisciplinary team in place or a network in place for the patient to access the resources that are needed.
Yo, Ryan, I know we got some more questions.
Yeah, there weren't many for the anxiety and stress in particular, but thought we'd take this time to talk about vestibular migraine, because I don't think that we cover that in any of the presentations. So Chrissy was wondering, are those with vestibular migraine more predisposed to MD,
Hello, everybody.
vertigo, anything like that?
Amy, do you want to take that one? It kind of cut out for a second, Ryan.
It cut out, Ryan. Sorry.
I'll repeat
again.
it. I'll repeat it. Chrissy was wondering, are those with vestibular migraine more predisposed to MDDS or positional vertigo or any other condition?
So with vestibular migraine, that's usually the condition that comes as secondary to other vestibular conditions. So, for example, long-standing BPV can turn into a secondary vestibular migraine, and even though you treat the BPV and resolve the BPV, then the patient might be left with a long-standing migraine. With MDDS, I think it's safe to say that that's kind of a completely separate issue. But Barani Society have come out with a very, very kind of strict diagnostic criteria for vestibular migraine and how you diagnose that. And essentially, you're kind of ruling out any kind of other vestibular disorder first, resolving those first, and then you deal with the migraine.
Got it. Ruth was wondering, what is the best type of specialist to diagnose and treat a patient with vestibular migraine? Is a neurologist, neurootologist, vestibular specialist? Who should somebody go to if they suspect they might have vestibular migraine?
Brooke?
Dr. Pierce, I think you're on mute.
Got it. Okay, gonna take this one. So basically with this one, Amy kind of hit the nail on the head. It's important to work in a multidisciplinary fashion. So typically the neurologist or the neurootologist is going to be the treating physician that's working with the patient for medical management. And then simultaneously, they're working with the vestibular specialist to rule out any other vestibular conditions. So that's where a lot of the diagnostic testing will come in, and a lot of the questionnaires and a lot of the follow-up. So usually it is that treatment approach with quite a few different specialists working along the way. Then as far as management is concerned, again, it becomes kind of a 2 and 3 kind of pronged approach where the physician continues to medically manage the patient. They are working concurrently, usually with a dietitian, or working with kind of the dietary components that also include lifestyle modifications and trigger identification, in addition to doing vestibular rehabilitation, which can be, with the vestibular specialist to include the physical therapist or occupational therapist.
Got it. There's a question in the chat from Victoria. With vestibular migraines, I was taught that they would not recover without being medicated first. Is that true or false?
So so in my clinic, we actually do some medication first by the physician, and you normally need to be on medication for about 12 weeks to make sure that you settle to it, and you're very, very closely monitored. And then as we know that you're kind of settling to that medication, then we'll put the vestibular rehab on top. I don't think that vestibular rehab on its own or pharmacology on its own works. I think, again, it has to be a very combined approach. And again, you can't just be given blanket exercises or blanket pharmacology. Like, we have to monitor you and keep an eye on you and see what's happening.
Got it. All right, that does it for the questions so far. If we want to take a brief break, Q.
I was thinking, maybe we jump ahead. We'll be a little bit above schedule. It'll be about 10 minutes. But if you didn't mind, while we're here, could we just go ahead and start and talk about Meniere's disease?
Good with me.
Okay, good. Brooke, you're good with that?
I'm good. Let's keep rolling.
Alrighty. We have Professor Dr. Leonardo Manzari. He's going to be giving the next presentation. Amy and Dr. Pierce, curious, how do you know Dr. Manzari, and what can we expect on his presentation on Meniere's disease?
So Dr. Manzari is the guy, certainly across Europe, Asia, and Australia, on Meniere's, and I think he's got between 60 and 70. I've lost count. He's got lots and lots of publications specifically on that subject. So he's kind of been, again, pioneering and pushing forward our understanding of Meniere's.
Understood. Well, we're going to go ahead and get into his presentation. I will see you all on the other side, and thank you for tuning in to Vertigo.
Good evening. I'm Leonardo Manzari. I am professor at the MSA ENT Academy Center in Cassino, the center of Italy. I am an otorhinologist and I work with dizzy patients since 30 years ago. My gratitude to be a part of this great team of experts and my absolutely joy to be in a part in this Vertigo Day. And I was involved to talk about what is Meniere disease and how it's treated. What is Meniere disease? Meniere disease is a clinical syndrome. A clinical syndrome affecting approx 50 to 200 per 1,000 adults. It's most common between the ages of 40 and 60 years. Prosper Meniere's. The disease takes its name from this guy. He was a French doctor who first identified that the inner ear could be the source of the condition combining vertigo, hearing loss, and tinnitus, which is now known as Meniere disease. Big issues is the problem to clinical classification. And in the last 20 years, probably, there are probably 30 years, there are 3 or 4 attempts to classify the disease. This classification is very important to obtain a consensus all over the world about the diagnosis of the disease. The first well-recognized classification was that came from this paper in 1995, published on otolaryngology head and neck surgery from the Committee on Hearing and Equilibrium Guidelines for the Diagnosis and Evaluation of Therapy in Meniere's disease. What the committee established that the diagnosis of Meniere disease was probably in 4 steps. The first step is a certain Meniere disease. The second one was definite Meniere disease, as you can see here. The definite Meniere disease was a stage of the disease that was probably characterized by 2 or more definite spontaneous episodes of vertigo that last 20 minutes or longer. And, this is very important, audiometrically documented hearing loss on at least 1 occasion at the time of the attack. Tinnitus or oral fullness in the treated ear, and other causes excluded. That's crucial. As I said, as I will say later, probably this is the key, since many attempt to find the etiology of this disease have been made. Since now we have no etiology, so we need to exclude other causes that probably causes this type of attack of vertigo. The third stage is probable Meniere's disease, and since possible Meniere's disease. The stage of certain Meniere's disease is probably post-mortem diagnosis and definite Meniere disease, and needs histopathological confirmation. 20 years later, the Barani Society, the society that involved all the otoneurologists all over the world, physiotherapists, and all over the world, made this paper published in Journal of Vestibular Research, named Diagnostic Criteria for Meniere's disease. And the key point of this paper is that the Meniere disease was reduced in 2 criteria to diagnose and to classify the disease, in a definite Meniere disease and probable Meniere disease. Probable Meniere disease is a stage in which the patient complains 2 or more episodes of vertigo or dizziness, each lasting 20 minutes to 24 hours. Another important key is the fluctuating oral symptoms, and not better accounted for by another vestibular diagnosis. For definite Meniere disease, 2 or more spontaneous episodes of vertigo, audiometrically documented low to medium frequency sinusoidal hearing loss, fluctuating oral symptoms, and not better accounted by another vestibular diagnosis. This kind of classification was accepted also from the Equilibrium Committee of the American Academy of Otolaryngology at the Neck Surgery, with this paper from Joel Gable, published in the same years in the Otolaryngology at the Neck Surgery. Well, diagnosis, very crucial step. The diagnosis is clinical, and clinically unilateral ear symptoms that can last for several decades. Attacks are typical, random, and episodic, approx 6 or 11 per year, approx 1 per month, 1 or per 2 months. Remission may last month to years, and this is very crucial for the patient, since the patient thinks that the disease is finished, but it's not true, obviously. It's typically not made at one point in time, the diagnosis. It may take months or even years to fully appreciate the clinical manifestation. Second step of the diagnosis. to maximize the treatment, it's crucial for the clinician to clinically distinguish MD from other independent causes of vertigo in a sort of memo that can reproduce the symptoms of Meniere disease. The third step is the variability in clinical presentation of the symptoms that I mentioned before, or better, vertigo, hearing loss, oral fullness, and tinnitus. This is very important. Accurate and full diagnosis may take many months to obtain. And this sentence speaks to the natural history and, above all, variable clinical presentation. So, when a clinician see a patient that arrive at a clinic with an acute attack of long-lasting vertigo, a major question facing the clinician is, what the cause of this attack is due to Meniere's disease, vestibular neuritis, or superior vestibular neuritis? Well, the patient comes in the emergency department with these symptoms, and imagine 3 patients that arrive in our clinic here in Cassino, and the patient show at the bedside examination this kind of bedside spontaneous nystagmus. On the first patient, these are very old video, but they are crucial to me to understand what happened with this kind of solution. Looking at the spontaneous nystagmus cannot be the ideal weapon to understand what happened in our patient. If you can see here, this patient show a spontaneous nystagmus that beat to the right, and the same for this patient, spontaneous nystagmus that beat to the right. The same for this the third patient here, as you can see, same very third degree spontaneous nystagmus that beat to the right. So 3 patients with the same spontaneous nystagmus pattern. In this case, 4 questions arise. Which side is affected? Which sensory region is affected? Can we come up with specific tests for each vestibular sensory region? Of course, but more important, we need objective measure. Because vestibular tests until 2005 were spontaneous nystagmus, as I showed you, calorics, head impulse test, and cervical bang. Spontaneous nystagmus. As I showed, the presence of spontaneous nystagmus tells you that there is an imbalance between the 2 sides, and the direction of the spontaneous nystagmus tells you which side, usually, but not always, more affected. In fact, the nystagmus beats away from the affected dysfunctional side. And but we have a problem. We are testing horizontal semicircular canal function, and spontaneous nystagmus sometimes, especially in Meniere's disease, could be strange tests, strange sign, clinical sign, since could be controlational, as Meyer and Van Melle in 2008 published, and Coed, a colleague, published in 2005. But the direction of the spontaneous nystagmus may change, as Benz and McClure showed in 1991 and 1981. So the spontaneous nystagmus is a variable indicator. Sometimes it shows the affected side, sometimes it indicates the healthy side. Calorics. Caloric stimulation is an old, very well known vestibular clinical test. Until probably 20 years ago, was the gold standard of the vestibular test. And this is a very low frequency test, which usually mainly stimulates the horizontal semicircular canal system. And the problem with this test is that the test is very unpleasant, and the patient dislike it. They feel vertigo and nausea. So, head impulse test is another bedside clinical test, just like this. This is a bedside clinical test that shows us, in this case, a clear corrective saccade when the head of this patient is turned to his left side. Very clear. But sometimes the things are not so clear, and we need objective measurements. To test the head impulse test, the gold standard is a surge coil, 2 coils of very fine wire wound in a silicone contact lens, but this is very expensive. Each contact lens costs approximately $700, and the problem is we need a very complex clinical assessment. So in the last years, since 2007, probably, Memish McDougall from a PhD from the Sydney Vestibular Laboratory invented and proposed to all over to the world of the otolaryngologists this kind of instrument, a very light mask mounted with a high-speed camera and a sort of 3 sensor that are able to identify the plane in which the head of the patient is moved. This is a trace obtained with the video head impulse test in a normal subject. When we turn the head to the left, eye and the head closely match, just like when the head is turned to the right. But we have also cervical vent to air-conducted sound and bone-conducted vibration or galvanics. And these are the results we can obtain this kind of results in Meniere disease patients, especially at the time of the attack. As you know, more recently, 2007, 2008, new vamp generation is born, recording myogenic potential from the high muscle to sound and vibration. And these are ocular vamp, O-vamp. And they are a new simple measure of otolytic function, and they indicate mainly the utricular-macular function. These are the answer from the test obtained with a vibrator, a vibration over the FZ point, and the only things the patient must do is looking at, as you can see in this pic. N10 amplitude. N10 is the first wave obtained from the patient that looks up. We are recording electromyography of the inferior oblique muscle, one of the extraocular muscle. And I repeat, when we record the N10, the N10 is this wave recorded under the eye, the contralateral eye. We have the information of the irregular neurons that respond to this powerful stimulation, just like a tilt for the patient, we record the function of the regular neurons from the utricular macula. So now we have two VAMPs, and 10 indicate primarily the function of the contralateral utricular macula. P13 of the C-VAMP primarily indicate the function of the ipsilateral saccular macula. That would close the circle. All the vestibular receptor can be tested at all. So, coming back to those three patients with acute vertigo, an absolutely similar pattern of spontaneous nystagmus that comes here in the Casino clinic. The first one is this lady with this pattern of spontaneous nystagmus. I tested there with the video head impulse test, band conducted vibration, FZ OVAMP, band conducted vibration, FZ C-VAMP. We obtained this record from the video head impulse test. As you can see here, a very clear cut black mountain, the eye, the slow phase of the eye movement indicates that the horizontal semicircular canal to the left does not work, while the right horizontal semicircular canal work properly. I tested there with OVAMP, and under the right eye, we found no N10, while under the left eye, we found a clear, beautiful N10, indicates that the right utricular macula properly works. Finally, I tested there with band conducted vibration, FZ C-VAMP, and we obtained a clear P13 N23 under the left sternocleidomastoid muscle, and the same obtained over the right SCM. Diagnosis: left neuritis. The second patient was this. This guy is a 72 years old man, come in the Casino clinic with the same spontaneous nystagmus pattern and the same at the same time of the acute attack of spontaneous vertigo. He complained nausea, vomiting, the same just like the first patient. And I tested him with the VHIT, and there is a clear difference between the first patient and this one. As you can see, we have an increase of the black mountain. The eye velocity, the slow phase of the eye velocity is increased rather than the first patient when we turned the head of the first lady to the left, we found a cut black mountain over turning the head to the left. Well, I test this guy with the same band conducted vibration ocular vent under the left eye, clear N10, under the right eye, very different from the first patient, an increased N10. The same for the band conducted vibration FZ C-VAMP, same results. So the saccular macula works properly, and the diagnosis is left attack of Meniere disease. Finally, very interesting, another patient. This patient was treated with intratympanic gentamicin for MD in his right ear 3 years before this attack of vertigo. And he came in the clinic with acute vertigo, as you can see. And in principle, he is in a right unilateral vestibular disease. So, unilateral vestibular deficit patient. So, why, if 1 ear works, this guy show me this kind of spontaneous nystagmus? I tested him with video head impulse test, and as you can see, we have a bilateral impairment of the horizontal semicircular canal. we have under the left eye no N10, while under the right eye, the N10 absolutely fine, absolutely beautiful results. So over the right SCM, a clear P13 and N23, the same over the left SCM. Diagnosis: selective left horizontal canal paresis with Bechterew effect. This kind of a new weapon, video head impulse test and VAMPs, allows the clinician to obtain new information about the very key point in diagnosing an MD. The very key point is the early MDs, and BC of AMP allow us to, as I showed you, to obtain this very crucial information, because at the time of the attack there is a crucial difference between the vestibular neuritis and the Meniere's disease. The pattern of the two diseases are totally different when we use bone-conducted vibration of AMP, but the spontaneous nystagmus was just the same. Here, the results of another patient at the time of the attack, as you can see, during the quiescence, N10 are beautifully the same, while at the time of the attack, under the contralateral of the affected ear, we can see an increased N10, while the C-band remain the same. And the V-hit is a very important new weapon for the clinician, since rapid fluctuation, there are fluctuations, there are not only in the cochlea of our MD patient, but also in the vestibular sphere of the labyrinth. So we publish this evidence, and I will show you two guys with the same acute attack of vertigo. In the casino clinic, we tested this guy with the same video head impulse test, and as you can see, acute attack of vertigo, no oral fullness for both of them, but one show us a clear pattern for vestibular neuritis, the other one show a different pattern, increased VOR gain. Tested both of them 7 days after. As you can see here, the reduced VOR gain, while the VOR gain to the right in this other guy remain just the same. And 20 days after, beautiful recover of the VOR gain for this guy with now definite diagnosis of definite Meniere's disease. In this case, we see that the VOR gain still low and a shower of covert and oversaccade indicates and confirming that we are in front of a right vestibular neuritis. Etiology. So the etiology is not well known, but these two guys, George Portman and Charles R. Pike, at the earliest of the last century, showed the post-mortem in this kind of patient that the affected ear was affected by a distended endolymph. So they introduced the terms of endolymphatic eye drops. Endolymphatic eye drops in 1983 was beautiful, in this beautiful paper reviewed from Harold Schuknecht, and he showed post-mortem the theory and postulated the theory of the rupture of the membrane, so the potassium ions affect the cells of the vestibular system and cause the crisis, the vertigo crisis. Another very important paper about the endolymphatic eye drop was this one from these three giants in our field, Somil Merchant, Joe Adams, and Joseph Nadol, and they postulate that the endolymphatic eye drops is probably a marker of Meniere disease, but it is a marker also of other disease. In fact, searching for Meniere's disease syndrome in 28 clinical cases, each case had eye drops in the affected ear. Searching for endolymphatic eye drop, 79 cases with eye drop in at least one ear, 35 have idiopathic eye drops, 44 cases secondary eye drops, 26 only with Meniere symptoms in idiopathic eye drops, 9 without Meniere symptoms, 2 cases with Meniere symptoms, and 42, this is very important, 42 cases without Meniere symptoms. So endolymphatic eye drops could be associated with also autoimmune inner ear disease, temporal bone fracture, autosyphilis, end stage of the autosclerosis, endolymphatic sac tumor, and acoustic neuromas, but could be not associated with vestibular migraine. So all of these disease act just like a memo with Meniere disease. So the clinician must be very, very careful in diagnosis Meniere disease without exclude this kind of other pathology of the inner ear. Endolymphatic eye drops may be necessary, but not sufficient for MD development. The natural course, typically progressive, fluctuates in a way unpredictable. Vertigo, early stages, frequency of acute vertigo attack increases during the first few years and may eventually decline to near complete cessation. This will not well understood. Natural course of hearing, a beautiful paper in 1984, and this kind of paper showed us how the hearing tend to stabilize, to a sort of stabilization all over the ear of the disease. The natural course is a big challenge when episodic nature of MD attacks affect the patient, because the asymptomatic periods in between the attack are not well understood, and positive effect of treatment versus alternative diagnosis that may mimic Meniere disease could affect our attempt of diagnose the disease. In the elderly MD patient, they may be not the typical MD-like temporal patterns. This may be replaced by severe imbalance or vague dizziness. I will jump to the treatment. The medical treatment in the Meniere disease allows or attempt to prevent or at least reduce the severity of and the frequency of vertigo attack. The treatment could relieve or prevent hearing loss, tinnitus, and oral fullness associated with such type of attacks. The medical treatment try to alleviate any chronic symptoms, for example, tinnitus and imbalance. And the treatment could prevent progression of the disease, in particular, the loss of hearing and balance function, which characterize the disorders and improve overall the quality of life. But no single treatment at this time has been shown to achieve all of these aims. Treatment approach. Usually, the clinician try to modify the lifestyle factor, for example, diet. Could be useful a mental health treatment, could be useful medical or surgical treatment. And the treatment approach try to find a separate goal to enhance patient preferences and preference-centered care to minimize the adverse effect of therapy in both scope and frequency. Since the etiology is not known, there are inherent limitations about the efficacy of proposed treatments exist. The variable or variables that cause symptoms in the setting of endolymphatic eye drops are not clearly understood, and the paper about Meniere's disease are poorly designed about the therapy and often showed underpowered or inadequate control. The last paper from otolaryngology and the neck surgery from Basur and colleague show us that many clinicians try to obtain specific, but I underline, unsubstantiated therapeutic approaches. This results in a tremendous practice pattern variation, in subjective treatment regimens, and subjective reporting of MD control. Traditional treatment approach, dietary, lifestyle, and trigger management approaches. There are medical therapy, and I will open a window on this topic in a couple of slides. Surgical, complementary or alternative approach, oral therapy, and that's crucial for me, oral or intratympanic medication. Medical treatment could be a medical treatment evidence base for Meniere disease patient. The Cochrane collaboration come in help of us. The first step, the most used therapy, beta-stim. With beta-stim for Meniere disease, can we use beta-stim? Many of us use beta-stim for Meniere's disease or syndrome, but the review of the Cochrane, first published in 2001 and updated in 2008 and 2011, with the objective to assess the effect of beta-stim in people with Meniere disease. Say at the end, in conclusion, there is insufficient evidence to say whether beta-stim has any effect on Meniere disease. The same for diuretics. The same conclusion. So, diuretics in update also from the Cochrane collaboration. there is insufficient good evidence of the effect of the diuretics on vertigo, hearing loss, tinnitus, oral fullness, the symptoms of the Meniere disease. And so there are no evidence-based treatment for this disease. Of course, the choice of treatment depends on hearing status. Usable hearing allow us to choose non-ablative procedures. Non-meaningful, useful hearing allow us to use surgical or chemical inner ear ablative treatments. The rationale for ablative approach is to attempt to convert an unstable ear to a static ear. Ablative approach are designed, above all, to control the vertigo attacks. So, I want to say thank you for the attention, good stabilization for your Meniere's disease, and above all, thank you from Italy. And I am very happy to be there in the Vertigo Day. Thank you.
Alrighty, we have Dr. Manzari live with us. We also have Dr. Pierce and
Right there in Italy.
Ryan. What are the questions?
How late is it there in Italy?
Hi.
Well, Dr. Manzari, there's
Hey.
a couple questions for Meniere's disease patients. Can someone still have Meniere's without hearing loss?
Yes, especially in the first step of the disease. The question is very interesting, since it's possible to find patients with only vestibular Meniere, and the question is debated for years, and probably the patient come in the clinic with this kind of Meniere's disease just in the first step of the attack, and we cannot recognize the disease since the patient show us audiometric problem, but we have now several weapons to understand that those attacks are related with the early stages of the Meniere disease. That's my opinion, of course.
Gotcha. There's a question here from Fiorella. I hope I'm pronouncing that right. What approaches are there for avoiding attacks? Does it include being aware of triggers of any sort? I guess how do you normally suggest to people to avoid Meniere's attacks?
Yes, very interesting question, but I think that actually we do not have any kind of procedure to prevent attack. Probably based on ABM evidence. Probably we can use many kind of procedure, such as therapy with diuretics or steroids or beta-stine. But the problem is who is the killer that open the labyrinth and allows the handling increasing. and so we cannot interfere with the killer. We just wait and see what happens.
Gotcha. Camellia is wondering, what is a drop attack? Is that something you mentioned in your, is this something that Meniere's patients experience, a drop attack?
In my opinion, the answer is no. Not all the patients experience drop attacks. Probably at the last stages of the disease, when the utricular macula is very damaged, and probably OVEMs now are the key to understand drop attacks. I saw 3 or 4 patients at the time of drop attack, just nearly the time of drop attack. I'm very fortunate here, since I stay in the middle of Italy in a small city, and I can see patients at the time of the attack and nearly the drop attack. So I can confirm that drop attack is a very dramatic situation for the patient, a sudden fall for the patient without the patient experienced no loss of consciousness, and above all, the patient is very involved in the fear to return in this kind of symptoms. So this is my position for the drop attack and the marking crisis in this kind of patient.
Gotcha. Brooke, anything you'd like to add or ask of Dr. Manzari before we kick it off to the next presentation?
Yeah, just the last thing that I'm seeing kind of in the live comments, you had mentioned beta histine. Is that something that is worth trying, that's kind of showing up kind of in the live comments from people?
Yes. Beta histine is a very controversial kind of therapy. I can say it works, but it probably works out just like a placebo. So I don't know. I'm not in the real right position to say beta histine is effective in all kind of Meniere disease.
Got it. All right. Well, thank you, Q. You want to kick it off to the next one?
Yeah, we can go ahead and start up the next one. The next one I believe we have is vestibular neuritis. Brooke, let me pull that up really quick.
Thanks,
Marco.
Doc.
Thank you for the invitation. Very pleasant.
Thank you. Ryan, quick question on Marco. Will Marco be joining us?
No, he's got patients that he's taking care of, so he will not be.
All right. Well, can you give a quick intro to Marco and who he is, what he's been working on? Brooke, I don't know if you have that info. I know Amy was behind this one.
Amy was, but we will get Marco. He'll go ahead and kick it off. It's going to be on vestibular neuritis and labyrinthitis. So this will be a good one for a lot of people to kind of see, following obviously the Meniere's.
Got it. Well, I'm going to jump into it. You all should be able to see my screen.
To everybody, I'm Professor Mark Mandala from the ENT department of the University of Siena in Italy. I'm a neurologist and a skull-based surgeon. And this presentation will be on vestibular neuritis, so acute unilateral loss of vestibular function, and especially on its diagnosis and management. The term acute unilateral vestibular loss is the one that we tend to use much more at the present time, because we really don't know if this kind of disorders in terms of etiology comes from the labyrinth itself, so from the semicircular canals and otolith organs, or from the vestibular nerve. So acute unilateral vestibular loss is probably the right term to define vestibular neuritis. From a definition point of view, the vestibular neuritis or acute unilateral vestibulopathy can divide in two forms. We know pretty well that the annual incidence of the disorders is 3.5 subjects over 100,000 people, and most of these patients are seen at an outpatient vestibular clinic. Even if from a symptomatic point of view, this is one of the most disabling vestibular disorders. So patients present generally with an acute onset of rotatory vertigo that generally lasts for more than 24 hours. So from a symptomatic point of view, patients are really disabled. So they have to often lay in bed. They have a really strong neurovegetative symptoms. So they're vomiting, they're really dizzy. It's also hard to keep their eyes open. The vestibular neuritis can be subdivided in the most frequent subclassification of the disorder, that it's called superior vestibular neuritis, and in inferior vestibular neuritis, that it's an affection of the disorder that is localized to the inferior part of the vestibular nerve. That is important because it's it goes up to the posterior canal and utricle. So from a symptomatic point of view, it's both very rare, and also the symptoms are a little bit harder to define. Generally, patients have subcontinuous dizziness, and also the oculomotor pattern is not 100% defined. When we speak about superior vestibular neuritis, generally these patients, and you will see in the following slides, they have a pretty strong spontaneous nystagmus. That means that these patients have an involuntary eye movements, and they are really ataxic. And right now, from a laboratory test point of view, the gold standard is to perform a caloric stimulation. So to put some hot and cold water in the ear canal in order to stimulate separately the two labyrinth to see if one is working less than the other, or you may perform a video head impulse. And we will go all through these examinations. We have to be aware that this kind of symptoms and oculomotor findings can rarely be seen also in acute central nervous system stroke. For example, acute pontomedullary brainstem lesion or cerebellar nodular infarction can present with the same symptoms and very similar oculomotor patterns. So it's very important that these patients could be sent to a specialized clinic where people are expert and neurologists, because an acute pontomedullary brainstem lesion or cerebellar infarction can put the patients at risk of his life. So the differential diagnosis in between these two disorders is it's very important. As you can see from this famous image, you can see that how the labyrinth neural innervation goes. So you can see there is a superior vestibular nerve, as you can see in the slides, that is the yellow one, that provide fibers to the lateral canal and superior one, and to the utricle, and an inferior one that where fibers goes to the saccule and to the posterior canal. And right now we have different kind of laboratory tests that can identify any pattern of deficit along all these tiny sensory structure that you can find into each labyrinth in every subject. Which is the natural course. So we said that this patient has an acute onset of rotatory vertigo, so they see the world spinning around them, that it's a really disabling condition, so they have an important instability. They have neurovegetative symptoms, like they vomit, and they have all this kind of symptoms. But the natural course of the disorder is that being between 60 and 70% of treated subjects recover labyrinthine function. That while only 40% of subjects who are not treated properly recover the labyrinthine function as measured with laboratory exams. Unfortunately, there is around 15% of subjects that do not recover from symptoms despite therapy. So this amount of subjects have a long-term disability due to the fact that the labyrinth is not working. And it's also hard to say how much the dysfunction of the labyrinth is related to this kind of long-term disability. But we know pretty well that vestibular rehabilitation can improve very much this condition. It's also important to define if those patients who are long-term still symptomatic may have some kind of residual dysfunction, or another kind of disorders may be related to the emotional distress caused by the acute vertigo that vestibular neuritis produced in the acute phase. There is an interesting data regarding the long-term disability that can produce vestibular neuritis, and it's very similar to what happened when we perform an acoustic neuroma surgery, so a major neurosurgical intervention to remove a benign acoustic tumor inside the brain. And those kind of patients, in terms of residual disability, are similar to patients who had a vestibular neuritis or acute unilateral vestibulopathy, as you prefer to call the disorder. So when we speak about the recovery from this disorder, we have different kind of recovery, and it's very important to define it, because it's strictly related to the patient's perception of residual, of his residual disability and his residual symptoms. So we may have a perfect recovery of the vestibular function. So all our laboratory exams are back to normal. We may have a substitution. So other sensory input may compensate for the dysfunction of the vestibular inputs, or we may have a central compensation. So our central nervous system is able to cope with just one vestibular system that is working properly. And we also have to differentiate recovery in between recovery at rest, so with the head of the patient still, that is pretty fast in the follow-up of these subjects, and recover during movements, because we all know that the vestibular system has a role while mainly while we are moving. So it's very important in giving us the chance to have a perfect vision and don't have a blurred vision or synopsial while we are moving. So if you want to stress the vestibular system, you have to move your head pretty fast. Just to give you an idea of what happened when you see a patient in the acute phase of vestibular neuritis, just have a look at these subjects. Here we are using the friends of Googles that are simple lenses that have a magnification of the eye of the patient to observe the nystagmus. And on the other hand, they remove fixation for the patients. So that will enhance the involuntary eye movements, so the nystagmus. Just to have a look. So, you know, our patient is very symptomatic, and you can clearly see this nystagmus that beat toward, sorry, I'll show you it again, that beats toward the right side. Okay, that means that our pathological side is the left one. So you may think to the two vestibular system as two arms of a balance, and when only the right side is working, the eyes are driven to the right side. There is also another very simple test that has been really a milestone in neurology. It's called the head impulse test, the clinical. Then you will see the laboratory part, the laboratory exam of this test that is called video head impulse test. And you can see that you have to move abruptly the head of the patient toward one side or the other, asking the patients to fixate your nose. And you will see clearly that when I will move the head of the patient toward the right, as you can see now, okay, we did it for the left, you see, sorry, the patients can easily keep fixation of your nose. If you do the same to the pathological side, that is the left one in this subject, you will see that at the end of the head movement, the patients will have to do another movement to come back to fixate your nose. And this is because the left side vestibular system is not working and cannot drive very fast the eyes in respect to a head movement. Now you will see. You see, at the end of these movements, you have a movement that is called catch-up saccade. You will see that to the right, patients, it's fine. To the left, you see at the end of the movements, he have to do a movement to come back to your nose, because the eyes were not driven properly by a non-functioning vestibular system of the left, on the left side. You can do the same with another test that is called head heave test, and you can see again we have a left side lesion. You see here, while in the previous test we were testing mainly the vestibular ocular reflex that arise from the lateral canal, here we are testing the utricular function, so a tiny end organ inside the vestibular system. And you will see that when we translate the head of the patients to the right, the patients can still easily fixate your nose, see? While when we are translating the head of the patients to the left, the patient has to do again a catch-up saccades to fixate, to refixate again your nose, because the left labyrinth is not working and is not able to drive properly the eyes. Another key sign in vestibular neuritis is called ocular tilt reaction. So, as you can see from this picture, this is another pretty important milestone in diagnosis of vestibular loss. You see that the patient has a tilt of the test of her head. So you see that the head of the patient is tilted to the right, and you can clearly see that you have a pathological disalignment of the eyes in respect to the horizontal plane. You can see clearly that the right eye is lower than the left one, and this one again will suggest a peripheral lesion again on the left side. Then you can perform another two bedside tests, because one of the really big advantage of neurology at the present time is that most of the tests that we can do can be bedside tests, and you can see how much this kind of bedside examination is important, especially when you have to differentiate a lesion of the peripheral vestibular system versus a lesion of the central vestibular system. So something like vestibular neuritis versus an acute stroke of the posterior fossa. And these are two conditions when, one, you need treatment that can be made in an outpatient setting. If you have a stroke in the posterior fossa, this kind of lesion put the patient at risk of his life, and these patients need to be admitted to the hospital, perform an MRI, and have proper treatment in an inpatient setting. Another test that you can easily do to identify which side is pathological, it's called head shaking test, and it means that you can shake the head of your patients, like we are doing right now with this lady. And if you have one labyrinth that it's working less than the other, to some extent you will get a nystagmus that it's beating toward the healthy side. So in these subjects, we have a nystagmus that it's beating to the left of the patients, and we will probably have a right side vestibular neuritis. Because when we are doing a head shaking, we are to some extent giving excitation to both labyrinth. If they are symmetrical and they're both working properly, you won't get any nystagmus because the two stimulation are symmetrical. If you have one labyrinth that is working less than the other, you will have an asymmetrical stimulation, and the healthy side will drive nystagmus to its side. Another very simple test that you can do, it's called mastoid vibration test, and you can use one of these simple mastoid vibrators that are used for example, for neck massage. And if you have one of these vibrators that it's around 60 to 100 Hertz, this kind of frequency are able to stimulate both labyrinth at the same time, in respect if you are doing it in the right mastoid, left mastoid, or forehead. And you will see in these subjects that, again, you can use the friends and Googles. We are doing mastoid vibration at the right side, and you will see this left side nystagmus clearly. So it means that our left labyrinth is healthy, and the right side has a deficit right now. Just to give you an idea to what happens to all these signs and what happens to other tests that we can do. And when we did this study, the gold standard was caloric stimulation. So we compared all these tests with the caloric stimulation. And you can see clearly that in the acute phase, all subjects present a spontaneous nystagmus, and all subjects has some kind of reduction of their response at the caloric stimulation. All the other tests have a different percentage of positive sign. For example, here you have the head shaking test that it's very sensitive. Then you have the head impulse test, the translational test, and the vibration test. Remember that especially head shaking test and head impulse test and the translational test are dynamic tests, and to some extent also the vibration one. If you test back these patients after 3 months, you will see that spontaneous nystagmus is present only in a short percentage of patients, and spontaneous nystagmus is the sign that it's most responsible for the acute symptoms. So patients see objects that are spinning around them, and generally the spontaneous nystagmus in a week disappear in most subjects. So in a week, patients generally, despite any kind of therapy they can do, they improve very much from a symptoms point of view, especially if they are static, so if they don't move their head. While when patients present spontaneous nystagmus, they are generally symptomatic also if they are not moving their head. And you can see that at 3 months there is a percentage of patients that can still present all other signs. So, as can happen often, these patients may not reach a specialized neurology clinic in the acute phase, and when they present to the neurology clinic, you may see only those signs. For example, you may see that the head shaking test is positive, patient doesn't have any more spontaneous nystagmus. You may see a head inputs test that is positive or a vibration test that is positive. But these patients may not have any more spontaneous nystagmus, and they may tell you that they are just feeling disability, that they don't want to have too much head movements, that they will feel dizzy if they move too much, if they move their heads, and so you don't only have to think about vestibular neuritis if you have a really important acute vertigo spell where the patient is very dizzy, it's vomiting, and see all the things spinning around him. But you may also see these patients as long-term disabled by some kind of instability, dizziness, intolerance to head movements. And you see that if you continue your follow-up, the percentage of tests that are still positive will lower down further. Okay, so right now, just to summarize, we saw with the case signs of vestibular neuritis, the major symptoms that, as you saw, we said patients in the acute phase has a rotatory spinning vertigo with that produce significant disability. They have strong neurovegetative symptoms like vomiting, for example, and following up these patients, the acute vertigo tends to improve pretty fast, it's something in between 48 hours and 1 week, but you may have a residual long-term disability. So it's very important to try to identify in which step of the disorder your patient is to provide the best possible treatment. Treatment for vestibular neuritis can be either medical treatment or rehabilitative treatment, so with vestibular rehabilitation. Right now we don't have an evidence-based, strong evidence-based gold standard treatment for vestibular neuritis. One of the reasons is that right now we don't know clearly the etiology of the disorder. There are 3 different theories. The most accredited is the viral one, so you may have some similar viral infection to what happened in, for example, in herpes viral infection. You may have a vascular disorder where you may have an infarction, selective infarction of the labyrinth, or you may have some autoimmune disorders, so some end organ autoimmune disorder. So treating the etiology, it's right now hard to suggest because the etiology of vestibular neuritis is largely unknown. You may want to treat the lesion, and we have few evidence that comes from magnetic resonance evidence that you have an enhancement of the vestibular nerve in the acute phase, but also this kind of evidence is pretty low. and in this case, you may want to treat vestibular neuritis with steroids, or you may want to treat the quality of life of patients suffering from Meniere disease. And in this case, you have to treat them differently if patients are in the acute phase or patients have a long-term disability or long-term dizziness. What can be suggested in any kind of patients is vestibular rehabilitation. So any kind of movement that where you have an integration of the three sensory inputs that determine our equilibrium, and I'm talking about vestibular system, so head movement, vision, and somatosensory input, so how the subjects feel his feet on the ground, and all inputs that comes from muscles, joint. These are somatosensory inputs. The integration of these three different sensory inputs determine our capacity of stand, of walking, and moving. So it's very important that any kind of vestibular rehabilitations could provide exercise where you have the activation of all these three sensory inputs. And so you can see that apart from specialized vestibular rehabilitations that is always improving the patient's quality of life, residual symptoms, acute vertigo, anything, but you may also suggest patients to perform, for example, badminton, table tennis, tai chi. Here, with this kind of rehabilitation, we have a much stronger evidence than the one we have with pharmacological treatment. This is a pretty famous page of a journal where you have vestibular neuritis subjects that have long-term residual dizziness, and the doctor just throw the pills to the patients, and the patient is asking, "Why, doctor, you are throwing me the medications?" And the doctor will say that you will improve much more trying to catch the drug than having the drug itself. And this is very true, because trying to catch the pills, he's using vision, vestibular system, because Our Lady has to move her heads, and somatosensory inputs, because she has to move her feet in order to catch the pill. So this is a really simple example of how much can be important vestibular rehabilitation, and we should start it pretty soon if we see that our patients is not recovery, and we will have always good results in terms of long-term quality of life if our patients is doing some kind of vestibular rehabilitation. Then we have also to know that which is the frequency of recurrence in vestibular neuritis, that it's very low. So after you had an acute unilateral vestibular loss, you have less than 2% of chance of having the same disorder on the other ear, or on the same ear if you have a complete recovery. But after vestibular neuritis, you may develop another vestibular disorder that is called benign positional vertigo, having again a vestibular neuritis on the same side or on the contralateral side is very uncommon. We have to say that while a unilateral vestibular neuritis, so if you lose the function of just one labyrinth, patients can have, despite residual dizziness or many other symptoms, they can have an normal life, even if the quality of life can be a bit lower. But if you lose both your labyrinth, the quality of life can be very low. That's due to the fact that vision and somatosensory input can compensate for a vestibular loss to some extent. So they can compensate only for lower velocity head movements, not for mid to high head movements, velocity of head movement. That means that if you are, for example, riding a bike or driving your car and you have a bilateral vestibular loss, you will see objects that move constantly on the horizontal or both horizontal and vertical plane. In this condition, it's called oscillopsia, and it is one of the most disabling conditions. So, in conclusion, if you have a look at treatment in vestibular neuritis, we may say that steroids can be effective in restoring vestibular function, but we have very few data on recovery from symptoms and recovery from long-term dizziness. You may use vestibular suppressant and antiemetics drugs only in the acute phase, and rehabilitation can be suggested in all subjects, and we really have good evidence regarding the long-term recovery from symptoms and disability related to the vestibular loss with vestibular rehabilitation. And we know that vestibular neuritis had a really low percentage of recurrence of the disease itself, but the percentage of patients who suffered from vestibular neuritis have a higher chance of developing another vestibular disorders called benign positional vertigo, and this chance is higher than normal population. So if a patient goes to the emergency department or to a doctor after a vestibular neuritis, the first thing to check is to have a look if this patient has a benign positional vertigo that can be treated much more easily than vestibular neuritis and with a stronger evidence. Thank you very much.
We've got Amy back with us, and we've got Ryan. Ryan, I know you've got some questions, and I am back as well.
Just a few questions, it looks like. The first one comes from Fiona. Can you comment on double vision as a phenomenon with vestibular neuritis?
You gotta go,
Amy
Brett?
or Dr.
Sure,
Pierce?
I'll take it. Yeah. So one of the biggest things when the ear's not working or the ear's not sending the signal properly, it will actually cause the reflex between the ear and the eye to be thrown off. So that vestibular ocular reflex. So when you have, whether it's vestibular neuritis and your ear itself is sending a weakened signal, then the perception of what's happening visually can change.
Gotcha. This one sounds like a physician question, so bear with me, Amy or Brooke. Do the vestibular neuritis patients with head tilt and stacked eyes have their vision checked for binocular vision dysfunction? Prism glasses, question mark?
So, go on, Brooke.
Nope, go ahead, Amy.
So, any patients that come through the clinic in the UK, if they have any kind of double vision or anything like that, they always will be advised to get the vision checked, along with the vestibular diagnostics. I'm not sure what's the protocol in the US.
Yeah, it's the same protocol. So it's important, obviously, that when we're ruling out any type of vision concerns, even when we go through the vestibular testing, we're looking at eye movement, not necessarily the actual function as far as crispness or your vision. So working with the ophthalmologist or the optometrist is really important, and kind of understanding when that last vision screening happened plays a big role.
Gotcha. And then Victoria was wondering, he said, I kind of missed this one too, but when he said that there was a name of a very debilitating condition, it sounded like he said posolotia or something. Do you know what he said?
I don't know. It might have been
oscillopsia. Yeah.
What was it?
Oscillopsia.
Oscillopsia. Okay.
Say that again, Ryan. No. Oscillopsia. Yeah.
Gotcha.
You can YouTube videos of what oscillopsia looks like, where people have tried to kind of recreate it. But oscillopsia can be a symptom of a few different dizziness disorders, so it's not just a symptom of vestibular neuritis.
Gotcha. Okay. Well, that seems like all the questions from the chat. So if you want to take us to the next one, Q.
Alrighty. Up next, we have Vertigo Day, a presentation that has been curated by yours truly, Amy. And I'm going to go ahead and get into that. Amy, do you have any things you want to say before I kick it off?
No, go for it.
Alrighty, here we
Thank
go.
you.
And today I'm going to talk about 3 subjects that Viviana Mucci, who unfortunately can't be with us today, she's done a lot of work on. So I'm hoping that me taking up the gauntlet can do some of her work justice. First thing we're going to talk about is visually induced vertigo. Now, that's a complaint that patients may have where they find going into visually stimulating environments quite tricky. So common examples would be the supermarket, airports, underground tube stations. They also may have trouble working with their phones, tablets, computers, and find that's very visually overstimulating. Typical symptoms are disorientation, general discomfort, postural instability, excessive fatigue, brain fog, agoraphobia, and anxiety. And then along with that pile of symptoms, they just generally, the vestibular symptoms tend to get worse. These symptoms lead to avoidance behaviors. So, of course, if you go to the supermarket and you feel overly stimulated, last thing you want to do is to go back into that supermarket. And so what tends to happen is patients start to withdraw and avoid those situations that they're finding extremely overstimulating and tricky. So let's break it down. So when we talk about vestibular conditions, we have central and peripheral conditions. So peripheral conditions come from the ear and central are generated from the brain. Now it's important to remember that vestibular rehabilitation can help both central and peripheral problems. And visually induced vertigo can be a symptom of central or peripheral or both. When we talk about balance, traditionally we'd say your balance comes from your ears, your eyes, and your feet, and then where you are in space. But actually there's lots of processes going on, and it's a multi-sensory integration of the brain, which is what helps us balance and how we know where we are and where we're orientated in space. So all these different components need to be working correctly and working together for you to feel like you are centered and balancing correctly. And if any one of these things is off, then that's where you can start getting the disorientation or stimulation. Now, the vestibular cortex in the brain is actually not in one area. So if we talk about the auditory cortex, which is the hearing cortex, that has a location. Vestibular cortex is mapped all across the brain, and actually the visual cortex, which is the part at the back, seems to be there seems to be a lot more weight given to the visual cortex in patients who have a visual-induced dizziness. And they know that from fMRI studies, where compared to somebody who doesn't have a visual-induced dizziness, that area just seems to be lights off it, because there seems to be a lot more going on there in that area. So what is the management for visually induced vertigo? Well, of course, we've got our traditional vestibular rehabilitation, but that on its own is not enough. There needs to be more than just the vestibular rehabilitation. And what seems to be being successful is oculomotor and optokinetic work, postural and proprioception training, pharmacology if the patient needs any medications, dealing with the behavioural aspects of avoidance. So if a patient is refusing or finding it really hard to go to the supermarket, how can you gently get them back into that environment? Emotional support for any kind of secondary anxiety issues that occur because of visually induced vertigo. And what's new and what we now have access to is virtual reality, which is great, and I'll go into that a little bit more. Okay, so what is optokinetic? Optokinetic is visually can be quite busy. Optokinetic work requires full field, so the patient has to be in a full visual field, and usually we give them black and white lines, black and white squares, swirls, all those kind of really highly stimulating signals. And the reason for that is you're trying to kind of desensitize that primary cortex and rebuild some resilience in how they take the visual information in. So if you think about it, you're kind of doing it in a safe environment, so the patient doesn't have to think about anything else. Just should be able just to absorb this visual information. And if it's done in short bursts, where the patient doesn't have to move, walk, talk, function, do the shopping at the same time, that's given them that rehabilitation's a lot more safe for them than doing it in real world. Don't forget about your postural controls. So muscle strengthening exercises, did the cat likes to get involved in those. Anything that can help with any postural control. And then virtual reality rehabilitation. So you can introduce the optokinetic work in a virtual reality situation, but you can also introduce real world situations in a virtual reality situation. A virtual reality environment. So let's think about it. If a patient is wearing virtual reality goggles, the stimulus is controlled, so they can take them away straight away, and you can give them very, very short bursts of that stimulus. You're taking away any proprioceptors, you're taking away other vestibular inputs, they can't fall if they're seated. And this work is just to help increase their confidence and increase their resilience to that visual information. And with the current environment that we're in as well, can be completed at home and it can be managed in a telemedicine environment. There are ways of doing virtual reality rehabilitation quite in a cost-effective way, or you can go and buy top-of-the-range virtual reality equipment. But there are ways to provide both services for patients. Now, if you remember this picture from at the beginning, where I was saying that the visual cortex seems to be more weighted in these patients who have the visually induced vertigo, that's what we're hoping to work on with stimulating the visual cortex. So if you're a patient watching this, what tips can I give you? So continual avoidance of environments will delay any recovery. But if you think about it, you need to do it safely, so you'll need some support working on whatever it is that you are avoiding. And if the supermarket, for example, is an issue for you, we don't expect you to be going in and buying full week shopping in one hit. Maybe just going in and picking up a newspaper might be your first goal. So you've got to really kind of limit your goals and stagger them appropriately. Limit any kind of screen time, even if it's leisure time, especially when you're trying to go through a rehab program. There's only so much capacity that your visual cortex can take each day. So by limiting any leisure screen time, it kind of gives you more to work with when you're working on your rehab. And sometimes working on a smaller screen will be better than the bigger screen. Looking at things like the brightness of your TV and reducing brightness can also make a big difference for you. During a proper rehab program, we do expect there can be some mild to moderate discomfort, but it's only in short bursts. For it to be safe, it's got to be just in short bursts. And I always recommend patients, if you put your disorientation on a scale of 0 to 10, we kind of want you at about a 6, no more or no less, for it to be doing the work, for it to be working. Remember that visually induced dizziness, so far from what we've seen in the studies, it improves slowly. So being patient with it and thinking about those small goals, just gradually increase. We don't expect you to be doing that full weekly shop within 10 days. You know, that might be a goal that you work up to over a period of a few months. With today's talk, there will be a link below with all the resources, and see those resources for any tips regarding any emotional triggers. So if you have a secondary anxiety, which is more than usual for patients with this visually induced dizziness, look at those resources and see if there's anything in there that might help you with those emotional triggers. And most importantly, try not to overwork the system. Overworking the system can end up setting you like 10 steps backwards. So it is one of those things where we have to just be softly. If you're a clinician and you're thinking about maybe looking at introducing this rehab as part of a program that you can offer, it's very important to assess for visual vertigo as part of your history. And that is important even if you aren't doing the rehab. I think it's a symptom that's kind of skimmed over when we do our traditional vestibular questionnaires. And again, there's a resource for you in the link below, which is a visual vertigo assessment scale. Use outcome measures for monitoring. Because the goals can be quite small and slow, it's good to use those outcome measures to show that kind of graduated improvement over time. Set the expectations with the patient that you only expect gradual improvement. so that they don't push themselves too hard as well. We'll use goal-orientated rehab, so really specific to that patient. What is it that they need? A generic rehabilitation program is not going to work. If you're thinking about using virtual reality, work in a real-world environment first, just to make sure that that you can see whether they're ready for the virtual reality environment. And when you first introduce the virtual reality, it's good to either be with them or be with them remotely on a virtual call, so you can really kind of monitor whether they're ready for it. And I think some people can not get on with it at all, and you need to be aware and monitoring that. Small bursts of use stimulus and gradually increase. So in our clinic, I might start you with a nice little walk in the park, or a walk along the beach, which is quite nice. Some nice sun music, not much going on, and then I gradually would make that a harder environment to look at, and by the end of it, you could be walking through Hong Kong in a virtual reality environment. The last one that I'm going to talk to you about is Debarquement syndrome. So what is that? So that's a very rare disorder, and it has it's when a patient kind of describes that they feel like they're moving, bobbing, or rocking, swaying, that kind of sensation, even though they're not. And it has two kind of onsets. So you have the motion-induced onset, which is where a patient can tell you the exact moment it started, post a car, train, fairground ride, anything like that. They can usually tell you when it occurred. There is another form where the symptoms are described as the same, but it seems to be more spontaneous and non-motion induced. Now, the Baranis Society has bracketed that under the PPD, through its PPD banner. It is a central vestibular disorder, so do rule out peripheral pathology. There are some peripheral conditions that may give out similar symptoms, so like notalifter dysfunction or post-BPPV, type of thing. Those patients might get that moving, bobbing sensation. For it to be syndromatic, it needs to be over or longer than a month present. So, usually, even when I go to the fairgrounds, the next 24, 48 hours, I'll still kind of get that movement sensation. And this is when it's lasted longer than a month. What is interesting in these patients is that they usually will say when they are in the car, they're happy, they're cool as a cucumber, and their symptoms seem to be a lot better. These patients like to be moving because they can't feel that they're feeling that they're moving despite being still. So why does it happen? What's the pathophysiology of it? We're not sure. We do know that there are functional and metabolic changes on fMRI, so changes in the brain when we look at the brain with fMRI. And some of the successful research that talks about helping patients with their symptoms talks about VOR, adaptation failure, or maybe a velocity storage. Now, the VOR is when your eyes maintain on a target. So this is where my ears are driving my eyes and telling them to look at my thumb. There's some sort of issue with that reflex. So what they do is they try and readapt the vestibular ocular reflex. First thing is they do a Precundus second test with you. So the Precundus second test gives us the information of which direction of sway that you have, and the idea is the patient closes their eyes, and we're trying to see kind of what direction they turn to. So this gentleman will gradually move to his right. So
his direction of sway is towards the right. Now, the measurements for these tests for the treatment was using posturography, and what posturography does is it tells the clinicians how much you're swaying with and without visual stimulus. So that might seem look clearer on the next slide. So if you look at this, this is the patient mapped where they kind of were swaying on the board. So on the left, that's normal, and you can see that kind of the red is all over the blue, which is what we want. Whereas a patient with milder debarquement, can you see the red lines are all over the place? That patient is kind of swaying. Okay. Then those patients were introduced to a optokinetic stimulus. On the left, that's taken from Margie's study, and on the right, that's taken from Dai's study. Dai's study asked you to tilt your head whilst you're looking at those difficult OPK stimulus. And Margie asked you to do a sway, but she did it in a slightly different way of doing the frequency. But all of their patients made a much improved sway result after a few days of having that OPK stimulus. So when they went back and did those sway scores, there was vast improvement, and the patient's self of sense and their self sway reduced dramatically. So that's two studies that have kind of replicated each other, and I know that Viviana is now, she's got a crowdfunding thing going on at the moment to see if they can do more work on this, but also measure the outcomes with fMRI. So for mild debarquement, make sure you rule out any peripheral vestibular disorder, any otolith dysfunction. OPK training seems to be the one to make a big difference to these patients' lives, but also, as we've talked and I've repeatedly said, it's multifaceted, so don't ignore the emotional, postural, proprioception. Is there a hormonal link? So women seem to get mild debarquement a lot more than men, and there needs to be further research into that. And then we definitely need to kind of get our heads around exactly what's happening in the pathophysiology to be able to improve treatment management in the future.
Alrighty, we're back. Mr. Cowdrey, what are the questions?
Yeah, first question for MDDS. When would you suggest people to go see someone if they suspect they have MDDS? Is it a timing thing? Because you mentioned, for it to present itself, it has to have I think over a month or something, you said. So when would you suggest someone go in and seek help?
So with MDDS, it's a very specific kind of description. So it's more that kind of rocking, bobbing, swaying sensation. I think at this point we should talk about if you have kind of a rotatory spinny sensation. If you get that continuously and it comes on pretty quickly, that's the type of dizziness that needs to be seen to immediately. The bobbing, swaying, kind of the movement on the ocean is more of it's not such an urgent issue. And we can't call it MDDBS, mild debarquement, until after a month. So I would say, as soon as you have concerns, you should be talking to a GP or a physician. And the quicker we can get you seen to, and the quicker we know about you, at least we can kind of monitor your situation and see what's going on with you.
Gotcha. How about, so we have a couple of VID questions. Does VID present itself in children? That's from Jane.
So children are a funny one because children you can't really give them the same questions that you can adults. So children you kind of figure out in between kind of what the parents say, what between the child says. That's kind of where you pick up what's going on with them. So for example, if you've got quite a young child, like a 4, 5, 6-year-old, mum might say to you, oh, they used to love playing in the playground, but now when we go, they hold on to me when we go to slides and swings. I would be interested to know more specifics about that question, really, because I'm not sure of the age range. Maybe the older teenagers might say that they have kind of that migraine as they get more aura, and the aura makes them dizzy. So it just depends on the age range and that child specific, and you would have to dive into that history a little bit more specifically.
Gotcha. Okay, and then the last one here for VID. This is from Jim. He says that driving causes him to get dizzy. It's probably the speed and the visual stimulus that's hurting him. But more generally, you spoke about taking small steps with reintroducing stimulus for VID. I guess, is driving one of those situations where you would recommend taking small steps, or is that something you should avoid altogether before you're fully recovered?
Do you want to take this one, Brooke?
Yeah, so I think with anything, it's a matter of working with your specialist and really kind of plugging into what that treatment plan looks like. So obviously, if not feeling comfortable driving or feeling unsafe driving is hindering his progress, that's something that needs to be discussed with the actual therapist that he's working with. But as a general rule, continuing to do activities that are comfortable and increasing your confidence level and your thresholds are really, really important. And so one of the biggest things that we're currently using virtual reality for is to bridge that gap between getting into the physical grocery stores or physically driving behind the wheel and slowly integrating the visual stimuli that you're able to tolerate with the real world thresholds that are fast, that change, that are different colors and different directions. So really kind of making sure that what you're doing is not, driving from here to Los Angeles on the 405 freeway in rush hour versus, maybe it is the first step after you've been working with your therapist for a while, going to the grocery store and grabbing, a gallon of milk and coming home. So there should be a progression and a process to it.
Got it. All right. Well, that's all the questions we have for this segment. Thanks for that, Amy. And Q, take us away.
All righty. We are about to jump into when to start your vestibular rehabilitation therapy with Dr. Margie Sharpe. Brooke or Amy, do you have any comments to add before we jump into this one?
Yeah, Amy, if you could take this one away, because Margie's got some really exciting stuff, and I know if you kind of kick things off, you'll give her a good start to this one.
Mm-hmm. So Professor Dr. Margie Sharpe, she's a leading physiotherapist in Australia. She's got a practice in Adelaide, and I'm sure the website will be linked in her presentation. Me and her have worked over many years, and she is another one who is very, she's pushing the boundaries and she's trying to get information dissemination to kind of push dizziness therapies forward. So if you're in Australia, she's a good one to hook up with, and she knows her stuff.
All righty. Well, we're going to get into it. If you have any questions, leave them in the chat.
Today I'm going to be talking about when to start vestibular rehabilitation therapy. The starting point is critical for a successful outcome. Vestibular rehabilitation therapy does involve a multidisciplinary team approach to our dizzy or vertiginous patient. And that's very important because there are a number of people such as the ear, nose and throat specialist, the neuro-otologist, occupational therapist, and so on, who are important people involved in the overall care of the dizzy patient. Vestibular rehabilitation, as we know it today, is a little different to when it first started. And it started back in 1946 in Great Britain. And Cawthorne and Cooksey, an ENT, ear, nose and throat specialist, and a physiotherapist, introduced a set of general exercises essentially involving movement of people. And they had some dizzy patients with balance problems. And these people were acute. That is, they were very, very dizzy, and they were doing these exercises at the very beginning, not 12 months later. And they made very astute observations that the people who underwent these exercises improved their balance, and the dizziness decreased. And a very important point that they stressed, and it holds true today, is that patients who were moving about, getting up, walking, and moving their heads about recovered more quickly than those who didn't. So we have taken that very important principle with us at this stage. And the great thing about the vestibular system, in fact, there are many great things, but from a rehabilitation point of view, the marvellous thing is that it's a very powerful system, and it has an inbuilt mechanism for recovery. And we call that vestibular compensation. And just a little detail about the compensation is that some people can have, let's say, an attack of vestibular neuritis, which is generally a viral infection in the inner ear. And so it happens very quickly. The person is very unwell, they have vertigo, and they can be very sick too. But we know that some people recover completely, and so we call it restoration. Now, what we do know is there are not a lot of people who fit that category. And they're an interesting group we really need to do more research on to find out what is different in their makeup that they get full recovery compared to most other people. What we use in vestibular rehab is looking at adaptation and habituation. And adaptation is getting the person again to do some very specific exercises, a little different to what Cawthorne and Cooksey did. And we can use vision, hearing helps us to balance as well, and the information from our joints and muscles, especially the muscles, because when people have vertigo, they find they rely a great deal more on their vision to help them balance than they did before. So that's adaptation. And another form of adaptation we've found in very recent years is that when one ear is affected, as with a virus that can happen, it's a little like two aircraft engines. One side drops down, the engine's not working if it's on the right side, for example. And so the vestibular system is very clever at bringing in some special eye movements so that when we turn our head, we run, we jump, we somersault, everything stays perfectly stable on the back of our eye, our retina. But with the virus in the inner ear, it doesn't work quite so well. So these special eye movements compensate, and we can maximize on those in our rehabilitation. So the other is habituation. Now the French have been, it was Alain Simont, a physiotherapist and a researcher, and several decades ago he chose to do habituation. So just think of yourself sitting in an office chair. What he and his colleagues use is far more sophisticated, but I think if you just think of yourself sitting in an office chair and you had vestibular neuritis, it involved your right ear. And so that was weaker, and you're wanting to try and bring back the asymmetry to being symmetrical, because that's how our ears normally work. So what they found, and they've recently published this, but they'd witnessed it for a number of years in the clinic, is that they put a person, so it's the whole body, you're in a chair and you're being moved to the weaker side. And of course, there are sophisticated parameters they've used, but that gives you the idea. So it's to actually encourage the weaker ear to improve and get stronger. And whilst you're doing that, normally when we turn our head, let's say it's to the right, and we're crossing the street, to the left, to the right, then the right ear turns on and the left quietens down. And when you turn to the left ear turns on and the right dampens down. So they have actually taken the system as it works normally and said, we're going to just work on the weaker side, and they have published some really nice results. So that's a really super way of doing it, quite apart from what has been done quite a lot is using, looking at something. I'll just get my, and I'll sit side on. So I'm just looking at a target, and it's a V on a background of stripes. So we get people to focus on the V and just to move their head a little to each side. And they've got to be able to see the V clearly. If they move their head too quickly, they won't be able to focus. So we gradually increase the head movement. And these exercises make people a little dizzy, which is good, but you walk a fine line in keeping people motivated whilst they're doing the exercises, and they need to feel dizzy. So that's the wonderful part of the vestibular system and how it works to the patient's, your advantage, as well as to the clinicians. Okay, so what's the next one? Okay, but there is a critical time. At one stage it was said, look, it doesn't really in people matter whether you capture them at the first or second week that they've had a bout of vestibular neuritis or 6 months later. And then some work was done with monkeys. And now the French group have actually this year published that it really needs to be starting within the first 2 weeks. And they did what I've just done, looking at a target and moving your head in parallel with people, and everyone was matched appropriately for the research program. So they also had people sitting in the chair and spinning, being spun to one side, their weaker side. And in both cases, irrespective of the program, the treatment program, the critical period was within the first 2 weeks. You would gain you would gain within the first 2 weeks the maximal compensation. And the reason why that happens is that the brain, the nervous system, is reorganizing itself. So it's good to capture the patient at that time so that we can work with the nervous system. So it's a win-win all round. And we want, and so do patients want, optimal functional recovery and to have a good quality of life. Okay, there are some other factors. It's very important for the patient to be thoroughly assessed. Everybody's different, and we need to look at what the individual is able to do successfully and what they're having difficulties doing. And also, the earlier we see people, the better for many reasons. It prevents a patient from choosing some we call maladaptive strategies, but strategies that are really counterproductive to their recovery. And for example, avoiding is like, well, I'm not going to do that movement because it makes me feel unwell. And very often it's like movement. You don't want to move your head. You don't really want to move around, get out of bed. It's more comfortable if you just lie or sit down all day, except you're not going to improve without movement. So to teach people that this is how you do it is very important. And yeah, sorry about that. We really want to give people the best opportunities at the best time. Another point that's really important is we either get them and prevent the anxiety or reduce it, because people worry about, am I ever going to be the same again? And so on. And they have lots of questions for us to answer. And it empowers and motivates people. There's someone that says, we can do something, we can help, and it's a team effort. So when it comes down to, I've been a clinician for a good while, vestibular rehabilitation essentially is learning. We're going to be teaching you how to overcome this loss of function. And we call it dynamic because the vestibular system is working very much in movement mode. So you turn your head, you get up, you walk to get a cup of coffee, cup of tea, etc. So we're moving around a lot. And that is its normal function. And so we look at different exercises appropriate for that person to help them, return to daily living comfortably, enjoying their recreational activities, and being able to return to work. So, and it can involve one ear, or it can involve both ears. And quite often, many cases, there's always a little bit of residual loss or damage left behind. But nevertheless, there are strategies we use to help substitute for that. So we're really providing people with new strategies, opportunities to learn new things and do that with us. It's like some people find it really difficult to stand on a foam mat, and they wobble a great deal after, especially if they close their eyes, after vestibular neuritis, I'll use as an example. And so getting them to be able to improve their balance on that surface is important, because most of the world is lumpy and bumpy, and you just can't keep walking on something that's firm, flat, and doesn't move. So they're the things that we do. And people, I find, learn very quickly, and they want to make a difference, so they're well motivated, and that's fantastic. Okay, I've really said the first before how we're teaching them new ways to do things to compensate for function. We, as I have mentioned before, we customize our programs because one hat doesn't fit all. So my take-home messages are: there's help for patients with dizziness and balance problems involving the inner ear, which we call peripheral vestibular disorders. But it's deep in here on each side, very, very deep. And so when we move our head, it moves, whether we roll over, we somersault, or we jump up and down. And most people who have an inner ear disorder, they don't require surgery or medication. Perhaps in the beginning, when they're acute and they're very nauseous, dry reaching or vomiting, then some medications are used to prevent that from happening. They're called antiemetics, and we use Stemetil a great deal, but there are different medications used in various parts of the world. The other important point is that early, and we can use either active or passive intervention. That's so important to get the best outcomes. And I just can't emphasize enough the importance of health professionals, everyone, from the general practitioner, your family doctor, to the ear, nose and throat specialists, the neurotologists, the neurologists, physiotherapists, occupational therapists, psychologists, and so on, really see that the person is referred quickly. I know what happens in my city is that many times people come late in the piece, and that could be months later. And things are just can be quite difficult at that stage than when they come earlier, and you can tell them what's going on and answer their questions, ease their anxiety and fear, so that they can improve. So I think the dizzy patient has a unfortunate time worldwide in finding the appropriate practitioners, but we're working on that. Okay. Yes, it's preventing the secondary problems of anxiety, and some people are just very anxious people, and the vertigo can unleash considerable anxiety. Someone may start having panic attacks, and you learn that indeed they've had a history of it, but they haven't had any for maybe a decade, and then they end up with an inner ear problem, and they're feeling extremely anxious over and above what we would anticipate. They can develop neck problems because they just go, oh, well, I'm not going to turn my neck because that makes me dizzy. So I will just, turn my whole body around to look at someone. And we need our neck to move. It's part of our basic movements from sit to stand, getting out of bed. And avoidance. If you don't know that it's important to start moving, but you need to pace yourself, people will just not move their head and go, well, it's better sitting down, so that's what I'm going to do. And that's really counterproductive. So, and it empowers and motivates patients. Being told there's nothing that can be done, which does happen all too often, is just dampens the spirit. But for someone to say, look, there is something we can do and help, means a great deal and boosts their morale. The other thing is, I can only say, ask around about, is there a dizzy or a vertigo clinic dedicated to, I'm calling it inner ear or vestibular disorders. But vestibular rehabilitation that I'm talking about today was established for the inner ear disorders. We know so much more now about the brain and the vestibular system in the brain, but this talk today is focusing on the inner ear and the rehabilitation for loss of function or partial loss of function of the messages coming in the ear to the brain on one ear, or it can happen on both. And the other is to find a local support group. In the United States, there's an excellent Vestibular Disorders Association in Portland, Oregon, and that's helpful to find a local support group. We will use it from here, not quite. We can't access everyone from here, but we can get a lot of valuable information from VIDA and let people know elsewhere in the world where someone can help them, whether it be France, Germany, Australia, New Zealand, or one of the many states in the United States. So I'd like to thank you for listening, and it's been a pleasure to talk to you, and I wish everyone all the very best. Thank you.
And we have
it's Margie.
Dr. Margie with us. Margie, my apologies.
Can you hear us, Margie?
Hi, Margie. Can you hear us?
I'm not sure she can.
Okay. Can you hear us? Okay, maybe not. Oh, can you hear us there?
I don't
Margie,
think.
are you there? Okay, nope. All right, Q.
Yeah.
Oh, there we go.
Oh wow, you can't hear us? It doesn't sound like she can hear us. Ryan, well, we figured that out. Any questions to start off?
Yeah, a couple questions. The first one would be, what are the signals or signs that you look for to make sure that proper compensation is taking place?
Okay, Margie, if you can't hear, I'm gonna hop on. Can you hear us? Nope. Okay. So one of the biggest things, especially when you start vestibular rehab, is getting a baseline measurement. And so, as Margie was saying, whether you're working with your physical therapy group or occupational therapy group, there's a lot of baseline testing that's happening, and a lot of measurements that are happening along the way, whether it's session over session or day over day. Or even week over week. So those metrics are being measured, whether it's based on sway, whether it's based on eye movement, or even going back to some of the initial intake questionnaires.
Gotcha. Can your, I think we always kind of talk about, once you learn to ride a bike, you really can't unlearn it, but can you unlearn some of these compensation techniques, or can your brain unlearn these compensation techniques?
So it really has to do with what the brain is taking in. So if the brain's not getting the information properly when we're speaking just to a vestibulopathy, it really is a matter of strengthening that signal so the brain can start integrating the actual processes again. So it really, it's a little bit different than riding a bike, because what you're trying to do is essentially help the brain get the information back in the full capacity. As far as the signal coming from the ear, making sure the visual system is playing its role and not overcompensating for that loss. And then the same thing with the muscle input. So once everything syncs up again with regard to the strength of the system and those reflexes can start, performing, then from that point, yeah, it's like riding a bike. So then you start kind of pushing the envelope with regard to physically what you're doing on a day-to-day basis.
All righty, let's do a quick audio test. Can Dr. Margie hear us? No. All right. Well, what we're going to do is we're going to move on. Ryan, you cool with that?
Yeah, there's a couple questions in the chat. Brooke, I don't know if they're a little too specific or not, but, just let me know. So Mirhan said, for a patient with Usher syndrome with bilateral total loss of vestibular function and impaired vision, would you recommend only substitution strategies? And if it's too specific, we can get that.
Yeah, it's pretty specific. I think this is a good question. We do have in the actual links, you'll be able to contact Margie specifically, but really understanding from a physical therapy standpoint, what exercises do make sense, and working through those substitution strategies with your treating clinician is really important. So if it's specifically for your specific case, definitely reach out to Margie, and with regard to exercises in general, that's kind of the process, kind of working through substitution of what you actually have left with regard to what the system can give.
Gotcha. Kim has a pretty prescient question here, I think. She said, any exercises to help with scrolling, since we're all on our phones all the time?
Okay, so I love it. So I think, again, with Margie, this would be a great question. But scrolling, usually what's happening is as you're going kind of up and down, kind of pulling the actual question from when Amy was speaking about the visual induced dizziness, and then, kind of pulling from what Margie was just saying. a lot of the gaze stabilization exercises, or when you're able to kind of find a fixation point and use that as a reference point, taking a break from the scrolling is going to be very important. And so we kind of pull from a few different disciplines, but just kind of, following that 20-20-20 rule, kind of in the ophthalmology and optometry world, where when you're looking at something specific, so let's say it is scrolling, or the 6 hours we've all been staring at each other on this vertigo day today, you want to be taking breaks throughout. So visually, you're going to stop, after 20 minutes, you're going to look at something that's about 20 feet away, find a gaze or fixation point to look at. So something simple that you're able to stare at for 20 seconds or so, and then come back to the scrolling. So that constant stimulation visually of the system is not good. So finding and using some of those, kind of gaze stabilization exercises are pretty important.
Got it. And then last but not least, Meg was wondering, would vestibular rehab still be useful after 10 months of MDDS dizziness?
Yeah, I mean, again, I wish we had better audio with Margie, but this is really important to kind of take home from all the physicians today, and then also a lot of the clinicians. 10 months of having MDDS symptoms, it's not hopeless. There is a lot that can be done. So making sure that the actual diagnosis is appropriate, that you've worked with the right specialist to understand if it's true MDDS, making sure that there are not any other kind of etiologies that potentially could be complicating things, and then working with the right specialist to make sure that you're getting the right rehab. Because again, speaking to Amy's discussion earlier, and a lot of what Viviana and her group is doing with regard to this MDDS space, is really exposing the system to a lot of different stimuli. And that could be a lot of the optokinetic stimuli, in addition to a lot of the dynamic platforms that are being used. So there's a lot of research that shows what works. There's a lot of room to continue to explore with what still needs to, kind of be coming out of kind of a lot of the research institutions. But yeah, definitely not, 10 months it doesn't mean you got to live 10 more, years like this.
Awesome. Well, I think we've been at it for 6 hours. We've got one final presentation from truly Dr. Brooke Pierce. Q, take it away.
All righty. Dr. Pierce, anything you want to say before we get into the age of innovation for dizzy patients?
No, I'm excited. Let's hear it.
All righty. I will get into it then.
Thank you. We're excited to kind of hop into how we put this all together with regard to technology and really the age of innovation for dizzy patients. So the first piece that we're going to jump into is virtual reality. So virtual reality is a simulation of 3D images that are computer generated while you're immersed in interactive environments wearing special electronic devices. So in the dizzy space, there are multiple kind of pieces of software that are used now with goggles where patients are able to be exposed to very simple, very repetitive stimuli in a 3D environment. The reason this is really important is because there is a big disconnect between a lot of dizzy patients and what they're able to tolerate from a visual standpoint. And so virtual reality is used in the therapeutic capacity for a lot of patients in order to actually bridge the gap between what we're getting in the real world with regard to lights and speeds and shapes and sounds, and what patients' thresholds are and what they're able to physically tolerate. So don't think of virtual reality in the sense of popping goggles on and just watching different video games or being exposed to like roller coaster rides. There's a very systematic approach to virtual reality when we're talking through the therapeutic application for dizzy patients. So a lot of times the virtual reality is providing a very calming, very simple, very visually understimulating environment so that the patient can very slowly be increased, or their thresholds can very slowly be increased in certain capacities. So what happens a lot of times with virtual reality goggles is patients are able to be exposed to optokinetic stimuli, gaze training, and going through a lot of habituation exercises in a very slow, controlled way at home. So they can sit with their goggles, they can go through the treatment protocols that the clinicians have set up clinically, and then maintain the progress that they're making daily or weekly in the clinic. So it really creates a very simple and a very easy way for patients to use the resources at home. So virtual reality in healthcare in general is used in a lot of different capacities. So kind of speaking globally, in the healthcare industry, VR is being used from everything from robotic surgeries to help surgeons during surgical procedures, to pre-op, helping patients when they're actually sitting there, if there's a lot of anxiety or a lot of angst before they're actually going in for the procedure, during labor and delivery for a lot of patients, and even then getting into just a lot of education for patients. So it's pretty amazing to be able to pause the environment that you're physically in and put on virtual reality and be able to actually immerse yourself in a different environment. So it's exciting for a lot of patients to be able to do that in kind of the global healthcare world. And then in the dizzy space in particular, we're able to siphon that information and make it applicable in a very specific way for our patient population. So what's really important from a dizzy space is how we're actually able to tap into two very specific senses. So a lot of virtual reality, it can expose and kind of engage all five senses, but particularly for dizzy patients, we're looking at the visual and the vestibular systems. And you know now from a lot of the talks that we've done throughout the course of the day, these two systems are very intimately connected to each other. And the virtual reality is just a dynamic visual environment that's going to be able to tap into both of those senses at the same time. And we can use them for rehabilitation and use it very effectively for rehabilitation for patients. So it's simple, it's easy. I think the take home that we really want to help all of you understand is that it shouldn't make you sick. Just because you put on, you know, your nephew's VR headset at the holidays or tried a VR headset to watch a movie at a certain point does not mean that that's the experience you should be having in virtual reality rehabilitation. The clinician that you're working with should be able to very systematically expose you to the right stimuli at the correct time to make this simple and palatable and effective. So the second thing that we want to tap into is going to be artificial intelligence. And so really it's just asking a simple question of, can we actually get machines to think for us? And that's really been kind of the point of a lot of scientific minds trying to tap into, can we really simulate human intelligence in machines? And the reason that that's really important is because dizzy patients are kind of bounced around from specialty to specialty. And so is there a specific algorithm that can be used and a very specific process that can be followed to get those patients to the right spot at the right time, or to see the right patient in the right order? And so it's really cool to think about what's happening in healthcare right now with regard to artificial intelligence. So the goal of artificial intelligence in healthcare really should be to simplify the lives of patients, doctors, and even hospital administrators to really make tasks easier that we're all kind of doing on a paperwork, standpoint and a questioning standpoint for patients, but quicker and more efficiently and effectively with less time and at a fraction of the cost. And so that's really where artificial intelligence comes in, and where it's really reinventing and reinvigorating what's happening in modern healthcare. And so if we're able to tap into machines and allow these algorithms to really predict, comprehend, learn, act, do all these things that we need them to do to make the end game easier for patients and make the end game quicker for patients, then it's a win-win on all fronts. So if you think just kind of as a general rule that artificial intelligence is machines doing the thinking of humans and taking these large caseloads and taking a lot of the human errors out of the game, that's where a lot of the excitement with AI in healthcare really comes into play. So with that, electronic medical records are going to be a big piece of that puzzle, and how a lot of the data is being siphoned, and then how a lot of the algorithms are being put into play, because the use of electronic medical records over the last 10 years or so has really allowed us to take patients' history, the diagnosis, any medications, put the treatment plan together, kind of the big picture in one spot. And so it's allowing access to evidence-based tools and letting the clinicians and the providers really make decisions on a global scale. So it's automating the actual provider workflow, but it's helping the patient experience be streamlined. I'm going to read directly from the slide, but the healthcare industry and computing technologies, so taking what we know with healthcare and then the computer technology itself, really is at a final point where these enormous amounts of data that are very complex can be put together and then really evaluated in a very meaningful way. And so the reason that's important, if you keep thinking about the dizzy patient and how we kept talking about how confusing it really is to kind of go from specialty to specialty and from wheelhouse to wheelhouse, it's important to understand that through artificial intelligence and trying to figure out how we cut and shape and put the patient into the right department, and then use the electronic medical records to really kind of look at the patient from a very, very big global scale, then all of this comes together a lot quicker than it used to. So what is the future of AI and dizziness, and really understanding how we make how we make very confident and very effective decisions. And so using AI as a decision tool to assist in the recommendations and the appointments and the treatment should really help kind of cut out the 5 to 6 to 7 specialists that patients are seeing. And the goal is to allow the fastest time to correct that diagnosis of the patient with the best outcomes. So really the kind of future of all of this, and putting the bricks and mortar of the clinics at the ready of patients, comes with the actual understanding of telehealth. And telehealth is the use of electronic information and telecommunication technologies to extend that care outside of the clinic and into patients' homes, and where the doctors aren't necessarily in the same space at the same time. And so we've talked kind of globally and internationally about the lack of resources for dizzy patients and the dizzy community. And so telehealth is an amazing way that we're able to bridge the gap between bricks and mortar clinics, where you're able to go in and physically see a physically see a clinician that's close to you, versus telehealth, where you're able to have access to access to doctors and other clinics outside of your city, outside of your state, or even outside of your country. And so this is really exciting, because not only from a diagnostic standpoint are you able to tap into different resources and different clinicians, but you're also therapeutically able to access different tools and resources that might not necessarily be right next door to you. So really, whether you're at home or you're at the office with telehealth, you're able to tap into your doctor through video or even phone. And this is important because you can communicate, via phone, via video, via, even email, to get the answers that you need in a very intimate way. And so you are able to very effectively and quickly communicate with your clinician that you've built trust with, and that you're able to tap into the resources that they're able to provide. So when we start integrating all of this, so how do you take all of this and put it all together? And the simple answer is that working with the right clinicians, they will be able to kind of direct and put these puzzle pieces together for you. And so most clinicians that are working in integrated healthcare systems or working in collaborative environments are very aware of what's already happening in the background. A majority of us are already using a lot of electronic medical records. The majority of us are already using telehealth resources. really tapping into what the artificial intelligence capability is. There are multiple hospitals and different facilities throughout the world that are currently using AI to triage patients and get patients into the right specialty a lot quicker and a lot more effectively. And so the bottom line should be what's happening internally from a healthcare and a provider standpoint should be being translated on the outside. And for the patient, that should just mean ease of use, getting your appointments a lot quicker, getting your information translated a lot faster from your treatment team, and getting the answers that you need a lot quicker too, and a lot more effective and efficiently. So we should be embracing this. We should be excited about this from all facets. You know, technology is the future, and using it responsibly and efficiently is really how this all comes together for all of us.
All righty, we have Dr. Pierce, Ryan. What are the questions? How are we looking? Ryan, you're on mute. I mean, Ryan he's on from today. I think 6
It's been
hours
a long
beating
day,
him.
you guys.
Yeah, it's beating that boy down. You're talking on mute.
Let's hear it,
It's
Ryan.
okay.
I don't know how video game streamers can do this every single day, but 6-hour stream. Thanks for everybody who rocked with us this whole time. I mean, we have Cities from Malaysia, and he or she must have started at 2 a.m. this morning watching.
Yeah.
We had people in the UK who just started the stuff at like 9 p.m. and watched through till 6 a.m. I mean, pretty incredible. It's amazing that everyone wanted to see this stuff that bad that they forewent sleep just to watch it. So thank you to everybody who joined us for that.
Kim says it was long to hang in there with vestibular problems. Kim, we tried to make it much more accessible to all of you all. We were taking feedback and suggestions we had the spelling, and y'all quickly.
Yeah, so I just wanted to say thank you, because I think just kind of speaking to kind of the global audience that we had, that this is, it's very interesting for a lot of patients because there's not a whole lot of resources that they're getting in an efficient way. So it's exciting. I know it doesn't feel good to sit through, 6 hours of anything, let alone when you don't feel good with a vestibular disorder. But really the whole point is to really, kind of siphon what we know nationally and internationally is happening, so that these resources make a lot more sense and they start to become a lot more mainstream, and that we're able to really continue to collaborate globally, so that, the end game is people feeling better a lot quicker.
Yep. And for everybody who's still watching too, this same YouTube link will be available afterwards, and we'll add some comments down below in the notes that kind of breaks it up to tell you, the mal de debarquements is at this time, the BPPV is at this time. And so we'll break it up so that you don't have to sit through 6 hours, and you can go right to the section you want to watch as well.
All righty.
Good.
Well, with that, Dr. Pierce, you're a legend. Thank you for
hey guys.
everything that you've done. Mr. Cowdrey, you're a great moderator. Thank you for your questions. And on that note, I will catch all of you all in the future, and I am out.
Bye, guys. See ya.